So it gives me great pleasure to invite everyone and thank everyone for joining us for the High Cancer Risk Population Virtual Conference Day 1. Without wasting any further time, I would introduce our program director, Dr. Uma Dangi, who's a medical oncologist from Mumbai. Uh, Welcome, ma'am. And can I request ma'am to please give the welcome address? Over to you, ma'am.
Thank you, Kashish, and thank you, whole team, for taking part in this high cancer risk population virtual conference. It is a little different topic, mainly with so much of advances in oncology. We realize that there are certain patients or certain people who are probably at a slightly higher risk for developing cancer, and trying to focus on these patients to try and address any preventive strategies or any screening is what I had in mind when we thought of when we thought of doing this kind of conference. So I welcome everybody for joining, and I hope this will be a very fruitful and a very wonderful discussion. So over to you, Kashish. Thank you.
Thank you so much, ma'am. We'll move on to our first session. Our first session is sponsored by Asparagus Nutrition. The topic is nutritional intervention colorectal cancer over DINI access modulation. And our speaker is Dr. Anubhav Mukherjee, who's a principal scientist from Asparagus Nutrition at California. With that, I'll hand over the mic to sir. Over to you, sir.
Thank you very much, Kashish. Uma, it has been really a wonderful time to organize this very important conference. I think nobody has thought of focusing on high-risk cancer population, and that is very important and need of the hour, as we can see from the tremendous interest that we have generated. We are also thankful to the chairpersons, Dr. Sudeep Gupta and Dr. Shyam Agarwal, for being there with us. As was mentioned, as per our Oncology Nutrition is sponsoring the first session, and I think they are doing a fantastic job of oncology nutrition. People most often focus on nutrition in terms of calories and total proteins that are normally consumed, but that is not what we want. And we have realized that nutrition, diet, infection, inflammation, and chronic illnesses, including cancer, have a very common link that often is forgotten. And if we can address this, we can actually make a big difference in the outcome of our patients. So it is my pleasure to invite Dr. Anubhav Mukherjee from Asparagus Oncology Nutrition. He is, as was mentioned, the principal scientist from the California office, and he is going to share with us thoughts on nutrition with respect to colorectal cancer. So Anubhav, over to you now.
Okay. A very good evening to all of you. My heartfelt thanks to Dr. Parikh and the organizer team. My thanks to Asparagus Oncology Nutrition team as well. It's a very pleasure to represent our company in this very prestigious platform, the High Cancer Risk Population Conference. And this evening, as already discussed, I'm going to reflect upon nutritional intervention in colorectal cancer, the role of diet and nutrition in particular in the colorectal cancer, with special reflection into our proprietary research is known as DINI axis, diet, infection, nutrition, immunity axis. So let's begin. My screen is shared, or
so it's not yet shared, sir.
Okay. Is it visible now?
Yeah, now it's visible.
I mean, it's full screen.
Perfect.
Okay. So your screen is visible now. Yes.
Okay, thanks. So before going deep into the subject proper, let's have an overview of communicable and non-communicable diseases. There is no need of any formal introduction, as everyone knows we are going through this pandemic situation. So a communicable disease, an infectious disease, is defined as a malady caused by a specific infectious agent or its toxic products that results from the transmission of that particular agent or its product from the infected person or animal and reservoir to a susceptible or prone host. On the other hand, the non-communicable disease, NCDs, is a disease that is not transmissible directly from one person to another. What we are reflecting here, that was our initial understanding. What we are trying to reflect here is the emerging role of the infection in the occurrence of NCDs and the non-communicable diseases. It essentially means there is a infectious part in the non-infectious diseases. There is a communicable part in the non-communicable diseases. And as time rolled on, we have witnessed that NCDs are associated with infectious risk factors, which actually blurs the distinction between an infectious disease and the NCDs. It is therefore absolutely required to get into the details of the linkage and the interaction in case of CVDs, cancers, COD, osteoporosis, T2DM, and many other NCDs. We are now exploring this particular field. That is one of our proprietary research. I made this title purposefully, deliberately. There is the communication in the non-communicable diseases. There are few people across the globe who have started thinking deep, pondering over this fact that there are non-communicable diseases communicable. Is there any transmissible part in the non-transmissible diseases? And in the Science Journal, as you can see, in 2020, there is a perspective article which is very insightful, where they have tried to discuss the transmissible microbial component in the NCDs. The NCDs can have the microbial component to be transmitted, which again lead us to the Darm organ theory of non-communicable diseases. As we can see, there is a Nature Review microbiology paper a few years back, 2018, where the authors have discussed this, the Darm organ theory of the non-communicable diseases. What it is actually, Robert Koch, centuries ago, he postulated that the suspected pathogen, the invading pathogen, is found in the individual with the communicable diseases. It can be isolated from the host and grown in culture, in vitro. And then it can cause disease when inoculated into a healthy host, in vivo. And it can be re-isolated from the inoculated host, it is ex vivo. And can we modify this Koch's postulate in order to understand the role of the transmissible microbial component for NCDs, where the dysbiotic microbiota can be found in the individual with NCD? Can it be harvested and grown in culture? Can it cause the disease when transferred into a healthy host in the similar way, in vitro, in vivo, and ex vivo? And can it be re-isolated from the inoculated host? And yes, evidence are there that it is possible and it is happening. And it has been proposed that the dysbiotic microbiota, particularly in the gut, can be transmitted to other individuals, which in turn altering their microbiota. So the dysbiotic microbiota from the diseased person can be transplanted and transmitted to the healthy host, and we can see the emergence of that particular disease in the healthy host. And this may contribute to the spread of the NCDs, including obesity, which is a key risk factor for the many NCDs, like CVD and IBD and other cancers and all. So here we can see the microbiota of an individual is really affected by environmental factors such as diet, smoking, alcohol intake, exercise, etc. And dysbiotic microbiota, you can see the environmental factors which can result in dysbiotic microbiota can be transmitted to the healthy host to other persons. In the spousal relation, people say like in the spousal relation can be deciphered based upon the composition of their microbiota. And the transmitted microbiota dysbiosis can be contribute to the obesity and other NCDs, in addition to the environmental factors. These are the risk factors present in the dysbiotic microbiota of the diseased person can be transmitted to the healthy host. Okay, so gut dysbiosis As we know, there are innumerable number of microbes residing in our system, our body. Alongside oral mucosa, vaginal mucosa, the majority of the microbes are residing in the gut, with bacteria being the most widely studied. But the causal relation between the gut dysbiosis and the NCD in many cases are still unclear, and this is subject to the intense investigation. The problem is mere correlation doesn't lead us to the causal linkage. It may well be said that they are happening simultaneously, precisely. For example, X can cause Y and X can cause Z. And Y and Z can both be dependent upon X. There is another possibility. Here we want to say that the Y is the cause for Z, but the gut dysbiosis is the cause for the NCD. So those causal links are subject to intense investigation, and much to our intrigue, much to our interest, we have seen that these dysbiotic microbiota are known to play some role in some cancers. For many other NCDs, we are now trying to explore this molecular pathway which links the gut dysbiosis and the NCDs. The story doesn't end there. We are also looking for immunomodulatory therapeutic nutrition to prevent and or manage the NCD. That makes the DINI hypothesis complete. So diet, infection, nutrition, immunity. From this picture, we can understand the role of the infection in development of certain cancers. Like Epstein-Barr virus is a cause for lymphoma. H. pylori can be a causal infectious agent for gastric adenocarcinoma. Hepatitis C virus for hepatocellular carcinoma. S. hematobilum is for bladder squamous cell carcinoma. Human herpes virus, Kaposi sarcoma. Human papilloma virus, head and neck cancer, cervical anal cancers. Now we are asking the question, is colorectal cancer being caused by the dysbiotic microbiota, or the link, the environment, the role of the environment is playing in the pathogenesis of the colorectal cancer? So colorectal cancer, as we know, is one of the most common cancers and carries a major health burden. Statistically, the global statistics, we can say it ranked third in the incidence, over 1.8 million new cases, and second in mortality, around 1 million deaths in 2020. As with many diseases, tumor formation in the large bowel is multifactorial. So both genetic and environmental factors can play roles here. As we know, the hallmarks of cancer, the genetic aspects are pretty clear as of now. There are upregulation of the oncogene, downregulation of the tumor suppressor genes, self-sufficiency in the growth signal, insensitivity to anti-growth signals, evasion of apoptosis, limitless replicative potential, sustained tumorigenesis, angiogenesis, tumor invasion and metastasis. Alongside, we know the reprogramming of the energy metabolism, and evasion of the immune destruction. But here we are trying to understand the environmental factors that contribute to the disease development for CRC. And the role of the microorganism present in the environmental factors in cancer biology has been increasingly recognized. As we were mentioning, around 3 multiplied by 10 to the power 13 bacteria are placed in the gut, and which interact. The colorectum interacts with many microorganisms with which the intestinal epithelium has a constant crosstalk. So the environmental factor is very important in the pathogenesis of the colorectal cancer. In case of genetic mutation for CRC, we have seen there is alteration of the chorionic flora, polyp development and others, altered GI tract transmission time, and modulation of the bile acid recycling, which lead to the excess exposure to the carcinogen with the colonic lumen. Promising biomarkers from the genetic aspect, we can see the circulating tumor DNAs are there, the CMS subtyping like consensus molecular subtypes are there, BRAF, KRAS, ALK, ROS1, NRTK1, CIMP, PI3K, macroRNA31, MYO5B. They're all predictive and prognostic markers involved in the therapy. And you can see the target group here. the insightful table. Here we can see the normal epithelium is being transmogrified into the adenocarcinoma in the presence of immune cells, in the presence of microbes. With a growing amount of immune cell being infiltrated and the growing amount of microbes present in the growing amount of crosstalk with the microbes are actually happening when we move from the normal epithelium to the adenocarcinoma. The hyperproliferative epithelium you can see here, and the adenoma, and then finally the adenocarcinoma. The immune cells are infiltrated into the tumor microenvironment, which is a known fact today. Initially, in the initial days, even clinicians and pathologists, they have long identified that some tumors are densely infiltrated by the cells of the both adaptive and innate arms of the immune system, and which gives rise to the inflammatory condition. It was initially assumed that such kind of interaction, such kind of infiltration of the inflammatory cells are actually set out to eradicate tumors. As time rolled on, clues were being accumulated that the tumor-associated inflammatory response has this ironical effect of enhancing tumorigenesis and progression of the disease. So the incipient neoplasias, where you can see the normal epithelium, hyperproliferative epithelium, the incipient neoplasias are turning into a full-blown cancer here. And here is the role of the inflammation in the microbiome. At the same time, the cancer is associated with bacterial infectious agent in 20% of all the malignancies. In case of colorectal cancer and ulcerative colitis, we have seen that 25% of the inflammatory condition, the inflammatory condition is contributing 25% of the total CRC occurrence. So inflammation alter local immune responses like IL-1, tumor necrosis factor, IL-8, the inflammatory bowel disease with the high risk of CRC through the alteration of the gut microbiota. There you can see the specific markers which are altered as we move from normal epithelium to the adenoma, adenocarcinoma. It's the mechanism of colorectal cancer and colitis associated cancer development. The persistent inflammation facilitates tumor promotion by activating proliferation. Here we can see the crosstalk among environment and genetic factors. So the environment, the aging, the diet, lifestyle, genetics, everything is associated now with this axis, this microbiota, inflammation, and cancer. Here we can see the crosstalk between the environmental factors and the genetic factors in order for an incipient neoplasia to grow into a full-blown cancer. CRC pathogenesis, we have seen that the microbiota associated mechanism involved in the pathogenesis of colorectal cancers. You can see driver bacteria directly procarcinogenic, the metabolites of the driver bacteria. We have seen the bacterial toxins, the passenger bacteria at the same time are playing their role. So the gut microbiota can influence colorectal carcinogenesis. There's a variety of mechanisms are there. Metabolites are genotoxins, the microbial derived factors, and some bacteria can directly procarcinogenic driver bacteria. And they are crossing the intestinal epithelium, and Wnt-p-catenin signaling is activated. You can see the DNA damage here, intestinal barrier breakage, NF-kappa B STAT3 signaling activated, pro-inflammatory cytokines are activated. So the host microorganism interaction contribute to the activation of the procarcinogenic signaling pathways that ultimately lead to the molecular changes that lead to the progression of the colorectal cancer. And these mechanistic components have the potential to be modulated for therapeutic or prophylactic purposes in the context of colorectal cancer. What is the clinical application? related to gut microbiota and colorectal cancer here, we can see screening of the biomarkers to detect the CRC adenoma in the asymptomatic individual, and prognostic and predictive biomarkers like clinical outcomes in patient with CRC and the predict treatment responses. So the type of markers we have already discussed a part of it: microbial genes, microbial metabolites, microbiota related serological markers like fecal samples are gaining more and more attention these days. Of tumor tissues are there. The modulation of CRC treatment to modulate the microbiota, to modify the microbiota to improve the immune therapy or chemotherapy responses or reduce their adverse effect, and modulation of the microbiota for the CRC prevention at the same time with the high risk or average risk population. What are the approaches involved here? Is a dietary intervention, of course, prebiotics and probiotics, fecal microbiota transplantation, antibiotics, postbiotics, or microbial metabolites. CRC associated microbes. This paper is very important, published from Harvard Medical School and MIT. And the authors have demonstrated how CRC is associated with the inflammation and the gut microbiota is playing their role. Streptococcus, Caloreticus, Enterococcus fascicalis, genotoxic Escherichia coli, again genotoxic Bacteroides fragilis, Fusobacterium nucleatum. They are playing their role in the pathogenesis of CRC. The screening, I must refer to this paper, Nature Review Gastroenterology and Hepatology, which came out in 2019, where we can see people from everywhere. We can see the population is coming from Austrian, Chinese, Danish, French, German, Spanish, American, Swedish, Chinese, and another this continuation of this table is here. Yeah, Japanese, Italian, German. So from all these studies, a big number of you can see the cohorts also, like around 203 CRC and 236 healthy co-control have been taken here. 367 CRC and 258 healthy controls are taken here. Study platform is shotgun sequencing and 16S sequencing, qPCR, and the fecal markers are also being deciphered here, like Fusobacterium nucleatum, like Escherichia coli, the genotoxic Escherichia coli, Clostridium symposium. They have screened for their role in the pathogenesis of gut microbiota related CRC. Here we can see the fecal sample from many cohort, and you can see the increased amount of bacteria present in the fecal samples. The method implemented here is also 16S rRNA gene, 16S shotgun, real-time PCR, qPCR, we mean, fecal and mucosal samples, and many of them, they are reporting like the Fusobacterium nucleatum, Bacteroides fragilis, and many other variations. They are coming in the like gut microbiota variation, GM variations are coming in the fecal sample. Here you can see the biopsy samples also, tumor tissue samples, and there also this F nucleatum is present, E facilis is present, and many other subtypes of these bacteria species are present, like B fragilis are present here, Providentia is present here. Similar methods have been implemented. In both tumor biopsy and the fecal samples can be screened. Fecal samples can be screened for CRC pathogenesis, and in the tumor biopsy samples also we can see the GM variations. It's a proof enough, like the GM, like gut microbiota is playing a crucial role in the pathogenesis of CRC. So undigested dietary residue from bacterial metabolism, they're reaching the colon. The distal colon, how you are going to the causal level. The excessive consumption of the amino acid, the red meat, like branched chain fatty acids, ammonia, phenols, indoles, amines, volatile sulfurs, and the proximal colon also. We can see the excessive consumption of the carbohydrate, and you can easily see the chronic fatigue syndrome, diarrhea, short bowel syndrome, type 2 DM as well. So it is a good microbiome and bad microbiome. Like L. acidophilus, L. rhamnosus, S. thermophilus, A. prostonezi, Akkermansia mucinifila, Bifidobacterium breve, and Bifidobacterium longum. These are referred as good microbiota. The good component in the gut microbiota. What are the bad components in the gut microbiota present, which are responsible for the CRC? The Fusobacterium nucleotum, H. pylori, Enterococcus faecilis, as we see, genotoxic, B. fragilis, genotoxic, E. coli, S. bovis, Enterococcus spp. Now, coming to the solution that we are trying to provide, it is one example of therapeutic immunomodulatory nutrition. What we are trying to provide here, for example, you see the polyphenols, the plant polyphenols, the phytochemicals, they have their role in increasing the anti-cancer potential of the drug, the chemotherapeutic drug as well, and reducing its toxicity. So totally the therapeutic index is increased here. They have their role in down-regulating and decreasing the occurrence, the chances of metastasis and angiogenesis. And they play their role in reducing the oxidative stress, increasing the apoptosis of the tumor cell. The probiotics, they produce SCFA, short-chain fatty acids, as a metabolite of the gut microbiota, which have their role in reducing the oxidative stress and reducing the DNA damage. At the same time, they negate the carcinogenic mutagens. They trigger the immune system to phagocytose the cancer cell. They also have their influence to reduce the cell proliferation and reduce the inflammation. PUFA, they have similar roles in reducing the oxidative stress and increasing the apoptosis, and also helping the chemotherapeutic drug to increase its anti-cancer potential and reducing its toxicity, overall increasing the therapeutic index. We're trying to trigger multiple pathways by the immunomodulatory pathways in order to reduce the cancer, the occurrence of the cancer, and the chances of the occurrence of the cancer. At the same time, when it is a cancer, how can we manage that? So this is the experimental part that we have designed. We have developed formulations, and we use those formulations initially to screen in the cell studies. Thereafter, we take this formulation to the murine model of CRC, and then our ultimate goal is to the clinical translation. And what we propose here is a low-fat, high-fiber diet, along with various other components like probiotic, prebiotic, postbiotic, different phytochemicals, vitamin, minerals for CRC prevention and/or management. So different formulations are generated based on the chosen ingredients, and different combinations has been made, which can hint at the personalized nutritional therapy as well. And they are being tested with or without antibiotics. Here I must mention one point. I have come across few papers. One of them is very important. It came out in Science 2017, where the author they treated it's a xenograft model of CRC. They treated the animals with antibiotics specific to Fusobacterium nucleotum, and they have observed there is a substantial reduction of the colorectal cancer. The direct correlation. I mean, it's a causal link. And here you can see the list of the ingredients what we have chosen, and based upon which we are making different formulations to screen into cell and animal, and finally taking it to the human. So metronidazole, as we are mentioning the metronidazole, of course, the antibiotic is not part of our formulation. We are testing our formulation in presence of antibiotic or in absence of antibiotic to see the synergy, the effect, if any. Probiotic we have chosen is Lactobacillus casei, Bifidobacillus lactis, L. rhamnosus, L. plantarum, is Brasonizi, and Akkermansia mucinifila is not approved in India. So we are keeping this out of our formulation for the time being. Prebiotic, postbiotic, some fatty acids are there, and in among other nutraceuticals like phytochemicals and vitamins and minerals, we have used anthocyanidin from grapeseed extract, apigenin from parsley extract, quercetin from apple extract, EGCG, green tea extract, silimarin, the Silbium marinium extract, elagic acid from pomegranate extract, allicin from Allium sativum extract, and of course, a little bit of ethanolides along with some curcumin, vitamin D, zinc, selenium, maltodextrin quantity sufficient, which is the base in the formulation. Then we designed our in vitro set of experiment where we have tested this formulation in both CRC and normal colon cancer cell line with the aqueous and ethanolic extract of the formulations to check their toxicity in the MPP assay. Then we have checked the expression of the tumor biomarkers in the CRC, BRAF and KRAS. And of course, we have checked the inflammatory cytokines, their expression in the Western blot. Like IL-2, IL-6, IFN gamma, TNF alpha. And then probiotics are also treated with the cell metabolite, the bacterial metabolite, and their growth and their inhibition are also evaluated. The effect of antibiotics of all the along with all the formulation are also evaluated in the CRC cell. In the second set of in vitro experiments, we have taken different strains of the pathogenic bacteria and treated them with the aqueous and ethanolic extract of the formulation that prepared, like Fusobacterium nucleatum, Bacteroides fragilis. The metabolites from the bacterial cell cytoplasm were extracted and again treated with this cell lines to check the growth and growth inhibition. And expression of the tumor biomarkers were followed, and expression of the inflammatory cytokines were also followed by this. In the animal experiment, we have developed a syngenic model for CRC in C57BL/6J mice, and we fed the mice with prepared formulations, and the tumor biomarkers for CRC were evaluated, and expression of the inflammatory cytokines were also evaluated. In the second set of animal experiment, we have developed xenograft with the Fusobacterium positive primary CRC, and we fed the mice with the prepared formulation in presence or in absence of the antibiotic, and then tumor biomarkers and the inflammatory cytokines are also evaluated. The third set of animal experiment is the FMT, like fecal microbiota transplant from human CRC to germ-free mice and normal mice to CRC mice. All these animal experiments in the whole transcriptome is being analyzed by RT-PCR. The challenges and possible solutions are there. For example, in the biomarker discovery, fecal microbial markers for CRC screening, there are some challenges, and the possible solutions are also being given here. And also for the prognostic biomarkers for CRC, we have seen the inconvenient sampling logistics are there, the like challenges, uncertain test performance across ethnic groups, and imperfect sensitivity and specificity. And all these possible solutions, we can make sure that in our research we implement all these things, like the combination panel of the different microbial markers, validation cohorts using different populations, identification of the core biomarkers across robust population, and standardized methods for the sample collection and quantification of the microbial markers. So the microbiota manipulation to improve a therapy, you can see that dietary intervention is of course required here. Probiotics to prevent CRC or improve therapy, antibiotics to remove deleterious bacteria, and fecal microbiota transplant. You can see the challenge here, and the possible solutions are also being given. Like lack of standardization and regulatory framework is there for probiotics to prevent the CRC, improve the therapy. So formalization of IND application on the other regulatory frameworks are required. That will give new direction to the research. And bigger studies for nutritional and bigger clinical studies for the assessment of the nutritional efficacy of different dietary components of course required. This is the future of microbiota theranostics. Theranostics means therapeutics, at the same time diagnostics. So diagnosis and the therapeutic approach. So biological samples from potential CRC patients should be screened for the diagnosis and of the risk factor present in the sample, the screen for the disease then. And therapeutic, we can understand the potential responsiveness to and or increased risk of the side effects of the therapeutic condition. Influence dietary and other environmental changes to decrease the long-term CRC risk. So tumor from CRC patient, the therapeutic, once the tumor is already there. So in the diagnosis, we can screen the fecal samples and other samples, the oral mucosa and other, mostly fecal samples have high propensity for the occurrence of the CRC. In the therapeutic, the tumor from the CRC patient, you can see the therapeutic, the enhanced therapeutic efficacy, and target the microbes within the tumor for immunomodulation. Treat with the re-engineered bacteria at the adjuvant therapy. So re-engineering the gut microbiota is coming as the future therapy of CRC and a few other diseases. Take-home message from my presentation today. So in a nutshell, we can say the gut microbiota plays an important role in the pathogenesis, progression, and the response to therapy in the colorectal cancer. Fusobacterium nucleatum, Bacteroides fragilis, they are nasty bugs. Delivering advent of fecal biomarkers in early detection of CRC, emerging role of diet and nutrition in CRC, and last but not the least, our proprietary research, DINI axis, and therapeutic immunomodulated nutrition, the formula that we are preparing with probiotic, prebiotic, different phytochemicals, and other micronutrients, they are showing great promise in CRC. Thank you. Thank you very much. My sincere thanks to Ion management for choosing me as a speaker in this prestigious platform. My thanks to Dr. Parikh for conducting this prestigious seminar here. Thank you. Thank you so much.
Thank you very much, Anubhav. Will you be happy to take some questions?
Yeah, sure.
So tell us a little bit more about what the DINI axis stands for.
Okay, sure, sir. The DINI axis is basically diet, infection, nutrition, immunity axis. Here we can understand it is not the diet-borne disease. It is the diet essentially means here, like diet actually encompasses the environmental factors. And the infections, the suboptimally treated infections which are present inside the body, they are playing some crucial role in the pathogenesis of various NCDs. To address them, we are using our therapeutic nutrition, which are essentially immunomodulatory in nature, and we are triggering the immune system to take care of the infectious, deleterious infectious part which are present in the gut microbiota in order to get rid of the disease.
Right.
So the gut microbiota manipulation at the same time in the presence of different phytochemicals, they have their immunomodulatory roles. So we are re-educating the immune system to understand the pathogenesis of different NCDs and understanding the causal link of the infectious, suboptimally treated infectious risk factors present in the system with the NCDs and eradicate them by therapeutic immunomodulatory nutrition. This is in a nutshell what DINI axis stands about.
All right. So fecal microbiota has been well known and studied for several years. In fact, there is a whole conference on microbiome that happens annually. And I believe the last year was the 7th annual conference.
Yeah.
How do we study the microbiota? What exactly do we do to identify whether there are good bacteria or bad bacteria?
So can you come again, please? I missed it. Sorry.
How do we do test for fecal microbiota? When the fecal sample is tested to see whether the microorganisms are good or bad, how does that test actually get done?
We have to lyophilize the sample, and then we have to screen them across the presence of different markers present in the bacterial strains.
So do you look for DNA, you look for RNA, you look for S100? What do you look for? in the microbiota.
So the transcriptome is very important here. Of course, the RNA.
Transcriptome, yeah. So I think RNA is very important, and that can help us. There was an article maybe 2 years ago where normal fecal microbiota is available as a capsule or a pill, and people can take that to replace their abnormal gut microbiota. And this is commercially available in United States. But in India, Dr. Shiv Sarin from the Institute of Liver Disease in New Delhi has used that for patients with chronic hepatitis and cirrhosis, especially patients who are waiting for a liver transplant. So these are patients who have a very poor child-birth classification. They have a very poor prognosis. Their life expectancy is less than 1 year. And when they were treated with the uh, homologous fecal microbiota, that means the relative normal feces were given to them, their 1 year survival doubled. So, just as you are mentioning about using the nutrition and various elements, restoring the microbiota, restoring the gut flora
Yes.
can actually help the patients in a big way in non-communicable diseases. So again, communicable bacteria helping a non-communicable disease. So what do you think about this?
I agree. I agree with that. The restoration of the gut microbiota is essential to prevent or to combat the NCDs. That is true.
Right.
That is absolutely required.
So let us assume that we now have a patient with colorectal cancer. I believe that there is a difference between colorectal cancer on the right side and on the left side, and it is related to the metabolism that happens in the gut. What is your opinion about right versus left? Does your intervention, does your dietary recommendation differ between right versus left colorectal cancer?
As of now, that has not been taken up with
Yes.
in our study. But as you mentioned, the incidence of right-sided colon cancer is more, and also the younger population. Those
Correct.
things are also mentioned in few studies that I have come across.
Right.
But as of now, the right versus left, this distinction has not been taken up in our study. But in future, we can take this up. Yes.
So supposing there's a newly diagnosed patient with colorectal cancer, he presented with weight loss, abdominal pain, endoscopy was done, a tumor was identified, a biopsy shows that it is adenocarcinoma of the colon. What dietary intervention do you first recommend for such a patient, newly diagnosed colorectal?
What dietary intervention do I recommend?
Yes. You mentioned that. Yeah,
yes,
you mentioned that. Correct. Go ahead.
Probiotic and the prebiotics.
What is the difference between probiotic and prebiotic? Because some of us may not know what is the difference.
Prebiotics are the food for the probiotics.
Right. Yeah. So many of us know about some oral drink which is made of yogurt that is considered as a probiotic. Yeah, commercially available Yakult, for instance. Do you think that is useful in patients with colorectal cancer?
Yes, if those specific strains are there, then it is useful. So that can be also personalized, like which kind of probiotic strains we are giving for which kind of colorectal cancer, which are detected with which kind of the specific kind of like bacterial intervention, like for Fusobacterium nucleatum and B fragilis. If those are present, then some kind of things can be recommended. Like that's what I understand.
Right. So there is one another question on the chat. I will just read it. Can you emphasize on the restrictions of food for colorectal cancer? Because it is mostly known that if animal milk proteins come in contact with cancer cells, it worsens the condition and helps the growth of the cancer cell. So let me start by answering that question. Please first let us get this out of our mind that animal milk protein contacting a cancer cell will help the growth. Okay. Please understand, cancer cell is autonomous. It is growing on its own. It does not require an external stimulus to grow. it will continue to grow irrespective of what else we do. So another example is like people say sugar should not be given to cancer patients. Cancer cells will continue to grow irrespective of what restrictions you do. So please do not think that a dietary restriction will prevent a cancer cell from growing. Okay. Having said that, what to do to reduce your risk of colorectal cancer? Not the patient has colorectal cancer, but a general population. I want to avoid a risk of colorectal cancer. Then I have to avoid red meat and I have to avoid smoked meat. At the same time, I have to make sure that my gut bacterial flora is as near normal as possible. And that can be done with normal dietary habits as well as regular meals. In addition, Aspara has several products that are specific for different stages of cancer. So when a patient has been diagnosed with cancer but not yet started on treatment, a patient is having specifically for colorectal cancer, a patient on cancer chemotherapy, and then a patient who is recovering from the treatment of cancer. So cancer directed treatment is over, and now the nutrition that is required. And each stage of the patient's disease requires a different mix of nutrients. And therefore, Aspara actually has different products that can be used for different stages in the cancer treatment.
Yes.
So I think that is something that is very important. Another question is what is the difference in probiotic, postbiotic, and prebiotic? So I think
Okay.
this question was answered, but Anubhav, this will be your last question before we move on.
Okay. So the postbiotics are the metabolites that's coming from the probiotics, and prebiotics are the food for the probiotics. In a nutshell, this can be answered like that.
So probiotics are ready to use. They do not need to be changed in the body to benefit the patient. Prebiotics are those which require some modification in the body before they become useful as probiotics, right?
They're the foods basically, like
Yeah, that's right.
inulin and fructooligosaccharides, and then postbiotic like MCT, like medium chain triglycerides, like SCFA, like short chain fatty acids. They're coming as
Right.
metabolites of the probiotics.
Yes. So since there are a few more questions, anybody who requires more information about diet and cancer related, you are requested to send your contact details, name, email address, and WhatsApp number to Kavina Creations, and then we will get back to you. We have run out of time, so we will stop here. Thank you, Dr. Anubhav Mukherjee, for your extent presentation. And I now hand over back to Dr. Uma Dangi for the next part of the conference. Over to you, Dr. Uma.
Thank you.
Thank you, sir, Dr. Parekh, and thank you, Dr. Anubhav. That was a really wonderful insight into the microbiota and how it can change the, completely the scenario and how it affects our body and can cause cancer. So coming to our next part of the program about the high cancer risk population. We are here. I welcome everybody, the faculty and the attendees, for joining us today. Oncology has come a long way, and we have treatment used to be very simple earlier, but now there have been last 2 decades have seen tremendous advances, not only in terms of the treatment and the number of drugs that are available for treatment, the type of drugs that are available for treatment, but also in terms of our understanding of the disease to some extent. We have understood that we have tried to dissect cancer cells at a very genetic level to try and understand how they behave, why they grow so much, and that this has led to the onset of precision oncology, as we call it today, where you try to test the mutations in a particular cell to understand what is driving that cancer growth and try to target it or attack it with certain treatment to try and control or curb the growth. So at this point, I would say we've also understood that there are probably certain people who are maybe more prone to develop cancer. I'm sure we all see in our clinics, younger and younger people coming with cancers, colorectal cancers, breast cancers. And we just had a very wonderful talk about the microbiota. Simple thing like germs in our gut can decide whether somebody will get cancer or not. So these are certain new things which are coming up, and we are understanding that there is a particular population or people who may be at a high risk for developing cancers. And this conference mainly is to try and understand how we can detect them in our clinics, in our practice. When they come to the OPD, is there some way in which we can understand that this particular patient is probably at slightly high risk for developing further cancers? Is there any way we can screen them early, or we can put a surveillance so that we can try and detect it early? And also whether there are any preventive strategies. So whether we can do something in order to prevent or to reduce the risk of occurrence of cancer in these patients. So with this in mind, I would now request to continue with the conference. Over to you, Kashish. Thank you.
Thank you very much, Uma. I think you have really set the context for the conference, and the tremendous interest that we have received for this high cancer risk population conference is a reflection of all the thought and the hard work that you have put in to develop this. Can we move ahead with the first next speaker, please? Dr. Selech Bhandari. Kashish, over to you.
Thank you so much, sir. It gives me great pleasure to introduce our next speaker, who is Dr. Selech Bhandari, who is a medical oncologist from Nasik. He'll be talking on the topic colorectal cancer risk determination, practical considerations. Over to you, sir.
Can you stop this screen sharing?
You can share your slides now, so stop the screen sharing, sir.
Is it visible?
Yes, sir, it's visible, sir.
Okay. Good evening, everybody. At the outset, I would like to thank Dr. Uma and Kavina Creation for giving this opportunity, and also making us go through this very interesting topic of risk determination in different types of cancer, and specifically with in the era of precision medicine. I think we have to be very particular about catching these patients young and at an early stage, so that we can give them curative treatment for these patients. So more and more understanding of molecular structure has given us an option to go into the depth of the disease. And as I always used to say around 20 years back, that the answer to malignancy will come from the drugs and not the surgery. So I think the things have really moved ahead, and we will be having a good options for most of the cancers once we understand more and more of it. So the risk factors, as most of the things are already discussed, I think in the previous talk, age itself is a risk factor for the patient with for having colorectal cancers, and hence the screening begins beyond the age of 50, except for a few people, and that's what we are going to discuss this time. For the high risk individuals, how the things differ from that of the normal individuals. Use of alcohol, lack of exercise. A lot of discussion has already taken place about the diet, so let's not go into those things. Personal history of inflammatory bowel disease, the Crohn's disease, and the ulcerative colitis increases the risk of malignancy. And the most focused part, what we are going to discuss today, is the family history and hereditary part of the colorectal cancers, which are these patients and how we can catch them earlier. So anybody who gets a malignancy of colorectum less than 50 years of age, we put them as young colorectal cancer patients. And this is one of the study from the West, where almost 1% of asymptomatic individuals, when were investigated, to have found to have malignancy, and weight loss of more than 5 kg could be one of the signs of early onset colorectal cancer. So we should have a very high index of suspicion regarding this malignancy, and particularly for any other malignancy when the patient comes with the symptoms. So the risk factors are modifiable and non-modifiable. So obviously these are the factors which are non-modifiable risk factor, can't do much about it. But definitely these are the patients which can be screened regularly. The disease can be catched in an early stage and can be cured. But these are the factors which are modifiable, and we should look into this, how we can modify this so that the incidence of malignancy goes down. Other factors which can be used to reduce the incidence, which we can look at once we go ahead, specifically in patients with hereditary cancers, is the use of drugs, or we can call it as a chemo prevention in few of the patients. So the hereditary factors, the other factors like type 2 diabetes, inflammatory bowel disease, and also there is some data about prior cholecystectomy giving rise to increased incidence of colorectal malignancies. So if you look at the other causes which we cannot modify, if you look at this pie chart, other than the sporadic, 30% of them could be familial and 10% could be hereditary. We'll go into the breakdown of this. If you have a first degree relative who is a young age colorectal cancer, then the chance that one will get a colorectal cancer is almost to the tune of 18 to 20%. And if you look at the breakdown of the hereditary cancers, it can be further broken down, further divided into the commonest one, which we can talk about, the Lynch syndrome, which is around 2 to 3%, non-polyposis colorectal cancers. Then we have the familial adenomatous polyposis, very high incidence of malignancy in this, almost to the tune of 100%, and the other syndromes which can be looked at. So what are the benefits of risk stratification in a colorectal? If you look at the three stages, what benefit does the patient get, what benefit does the clinician get, and how service provider also benefited if we are able to risk stratify a person who may or may not have a malignancy. For a patient, if we know that the patient has a high chance of getting malignancy, we can call them from regular screenings and early diagnosis, which will lead to an improved outcomes. Decision making for the patient also becomes easy if the patient falls in a high risk category. Then the patient himself or herself is convinced about the screening procedure, and the patient comes regularly for the checkups. For a clinician, especially in the COVID era, if you know that the patient is not a high risk, no need to really call patient for regular follow-ups. Maybe hopefully in a year or so we will come across this and the things will be a little better. But the decision of doing investigations and colonoscopies will be easier for a clinician if we have a risk stratification of these patients. For a service provider, obviously the cost is something which needs to be looked at. So the patient who are having a low risk may be called up at less frequently, less investigations to be done, and hence the health service cost will be reduced. So the potential biomarkers in the colorectal cancers which are at risk would be the commonest one, which we really are using it day in and day out for quite a long time, is a fecal blood test, which could be in the form of immunochemical test, which is not interfered by the dietary habits, whereas the guaiac fecal local blood test can come as false positive as well. The circulating tumor DNA can be checked, but the cost is something which is prohibitive. However, this is also one of the options. Not much convinced about the VOCs, the volatile organic compounds, where it can be checked in urine or breath. But however, that's also one of the options given in the literature. So how do we categorize this risk stratification? The best and the easiest one I could get is the familial family history of colorectal cancer patients could be divided into an average, moderate, and high risk. The easiest way is the average risk is something which does not fall into the moderate and high risk. The moderate risk familial colorectal cancers are the ones which have one first degree relatives diagnosed under the age of 50 years, or at any age, but two first degree relatives which are diagnosed. So this could be one which is in the moderate risk. The high risk would be a family with a cluster of at least 3 affected first degree relatives with colorectal cancers diagnosed at any age. but should be across 2 generations. So this is the easiest way and to remember the 3 the risk stratification of moderate, high, and an average risk. So the first thing what we do, and after reading all this, I am convinced that if you have a patient who comes to you, at least we should start doing an MMR for on the blocks and try to find out whether there is some genetic predisposition or anything which we can find out. So all the patients, irrespective of whether we have a somatic, because it has a role not only in a genetic way, but also a therapeutic way as well. So any of these patients, and especially the younger patients who come, we should definitely do an MMR status. Talking about the commonest hereditary HNPCC or the Lynch syndrome, most of them, as we know of, originate on the right side of the colon. Most of them are either metachronous or synchronous to begin with, or subsequently appear in young age. So right-sided. So if we have a patient with a right-sided, young patient with a right-sided colon, I think we should definitely try and investigate for Lynch syndrome. And they may be associated with extracolonic cancers as well, like endometrium, ovary, stomach, urinary tract, bowel, bile duct, pancreas, subcutaneous skin tumors, and brain tumors. Clinical features, the pathological features would be in the form of poorly differentiated or aggressive tumors like signet cell features. They may have underlying inflammatory bowel disease like picture on an histopath. And they, most importantly, they also have significant infiltrating lymphocytes. And that's why we all know that these are the patients who do very well on immune checkpoint inhibitors. The sequence one of the diagnosis is obviously identification of a germline mutation in MMR gene. So if we have a colorectal cancer patients, we do MSI on the tumor, and if it is abnormal, we look for the MLH1 loss, MSH2, MSH6, or PMS2 loss. And if there is an MLH1 loss, then we go for the test of hypermethylation analysis, and then go for genetic analysis to look for Lynch syndrome. Those patients who have hereditary cancers, surveillance is something which is very important, so that you can catch them early. And early disease means we will be able to cure these patients. So the patients with Lynch syndrome are recommended colonoscopy 25 years onward or 23 years onward, depending on whether they have MLH1 or MSH2 loss, or MSH6 or PMS2 loss, and should be screened every 1 to 2 years. Obviously, for other malignancies also, we should have keep the mind open to look at other malignancies which are associated with Lynch syndrome. If you go for familial adiposis surveillance guidelines, this occurs earlier, though the incidence is almost 1 to 1.5%, but very, very high chance of turning into malignancy. The average age where the screening is recommended is between 12 to 15 years, and to be done every 1 or every other years. To be looked at other malignancies also, especially at the young age, hepatoblastoma is something which could be seen. As compared to the high-risk individual, the screening in average risk individuals, this is the North American data, where the colonoscopy is not very frequent. Maybe after 50, one can do every decade. But to test the fetal occult blood every 1 or 2 years to check whether there's an occult blood in the feces. So if the patient has is not hereditary but has a family history of colorectal cancer, and you have excluded Lynch syndrome and polyposis, like we discussed, the screening becomes much more earlier. If you have a moderate risk, then colonoscopy at the age of 55, and if nothing is there, maybe just the normal screening pattern should be followed. While those with high risk individuals should have colonoscopy every 5 yearly from the age of 40 years onwards. So for the family history, there is a different protocol, and then for those with hereditary syndromes, there is a different protocol. So this is what one follows when one is managing Lynch syndrome, to do a colonoscopy at 25 or 35 year onwards. Looking at the therapeutic aspects, I think all the patients with young patients with metastatic colorectal disease or those with Lynch syndrome, they are likely to have a very high MSI. And this data from Keynote 177 shows that I think all these patients with high MSI, when this study was done with pembrolizumab versus the investigator's choice of chemotherapy, uh, we can see that in the pembrolizumab and the chemotherapy arm in this particular, because the MSI were high, those most of the patients were having a right-sided as compared to that of the left-sided tumors, and the PFS was almost double when pembrolizumab was used as compared to the standard of care chemotherapy. Those patients who had a duration of response, we can see that the duration of response was sustained over a long period of time when pembrolizumab was used. So, as this trial was positive, those patients, especially those patients with Lynch syndrome, which are likely to have a very high MSI, if they have a metastatic colorectal disease, I think this is a drug which should be used in these patients. If you look at the chemo prevention, can this cancer be prevented? This is a long-term study, the CAP2 study, where a 10-year follow-up was made for the patients were given aspirin. It was a double-blind randomized placebo-controlled study. So we had, there were patients which were given 600 milligram of aspirin versus that of a placebo. And you can clearly see that the cumulative incidence of colorectal cancer was less if patient has consumed aspirin versus to that of a placebo. And the same was seen with the other cancers occurring in the Lynch syndrome. So aspirin had an advantage over placebo if these patients. So this is a drug which can be used in a chemo prevention of these tumors. So to conclude, the risk determination guides us basically for the surveillance procedures which can be done, so that the patients can be diagnosed earlier. Risk determination guides us for an early screening and early detection of colorectal cancers. It also gives guidance about the risk-based chemo prevention method. But I think what we need is a validated multivariable risk prediction model which can tell us, which can further differentiate this uh, classification. Thank you so much.
Thank you so much, sir. We'll move on to the next presentation. Our next speaker is Dr. TP Sahu, who's a medical oncologist from Bhopal, and he'll be talking on the topic screening and risk reducing strategies in non-familial high risk population for colorectal cancer. So, with that, I hand over the mic to TP Sahu, sir. Over to you, sir.
Yeah, thank you, Kashish, and thank you, Dr. Uma, for giving me this opportunity. And this is a topic which most of us don't normally go through, or normally don't have a lot of conferences, or we don't attend most of it. So in next 10 to 15 minutes, I'll be speaking on the colorectal screening and the prevention of the non-familial ones, and specifically more so on the high risk group. So Dr. Shailesh has made my job quite easy. Some of them might be repetitions, but I'll try not to repeat it and probably add some extra data to what is already been told. So if I look at the NCCN and look at the recent NCCN, how it has gone through, if you look at the average risk and increased risk, they put through the average risk more like anything beyond for 50. There's a lot of debate going on. Should you be making it to 45 versus 50? Although most of the guidelines still stick to the 50, but there is a consensus going through, at least in the high risk patients, more so like the African Americans in the US, where there's a higher risk of colorectal cancers, you will reduce it to 45. So that is why the average risk of more than 45 comes into. The second thought that's coming in, which I will be speaking in that subsequent slides, is that there is a rise in the colorectal cancers in the young, especially below 50. There's a 22% rise that has happened in the last 2 decades. So looking at that, the debate is on, should the risk factor, should the screenings be starting at a relatively lower age, and could we reduce it to 5 more years to 45 years? So this is where the average risk is. Other than that, they should not have any other histories like what Dr. Bhandari has already spoken about, the negative family history, no history as such of colorectal cancer in the patient itself, no history of adenoma, sessile serrated polyps, and no history of IBDs. So increased risk, if I look at, because I know Narayan will be speaking on the familial, I'll skip that. We need to look on, concentrate on who would be the high risk. The classical teaching has been those with the inflammatory bowel disease, like ulcerative colitis and Crohn's disease. Those is the positive family history that I'm skipping. But those are the patients without a family history have had a history of colorectal cancer themselves. That would specify and classify into high risk. Apart from that, anything that is there, I'll come in the subsequent things. There are some literature on few other patients who could be looked into at the high risk. These are the familial high risk syndromes, which I'm skipping. So when do we start CRC screening? If I can go through, usually at age of 50, but you can start earlier if it's a family history, personal history of CRC, inflammatory bowel disease. Yes, that is a sure shot indication for that. And the race, African Americans, definitely the risk group where they are thinking of starting it at the age of 45. Where should be the alarm symptom for below 45 years is coming through, because as I told, there's a 22% increase, and this alertness should come in a young, especially when they come with change in bowel habits, a decreased hemoglobin or a rectal bleed. They need evaluation even if they are young. So what test? Very clearly spoken. I just will be little more elaborative on that. We have options of flexible sigmoidoscopy versus colonoscopy. That is something which I put it as a invasive procedure. So if someone wants to do a colonoscopy, which is the most accepted standard, that would be once in 10 years, except for in patients whom are particularly high risk. I'll come to that in a minute, who you might need to do colonoscopy more frequently. But if you're doing a flexible sigmoidoscopy, it would be repeated once in 5 years. So that's something very important. Colonoscopy remains the standard. Most of the screening modules have accepted that to be the one. US really accepts it. But if you have done a good colonoscopy, a complete colonoscopy till up to the cecum, the bowel is well prepared, and the person doing the colonoscope is a nicely trained person, and you would give adequate time for the colonoscope. You just cannot go in and come out. If you're doing a screening colonoscopy in 2 to 5 minutes, you need to be very, very precise. And that is somehow, that is very important. If that is not done, then you need to repeat even a colonoscopy after a year. If the bowel is not prepared well, if you have not gone through the full colon, then you might need, and you will need to do a repeat colonoscopy after a year. If you're doing a flexible, the point is you only are looking at one side of the colon. The scope should be at least 60 centimeter in length. That's what the recommendation is. And you can add a fecal test, as already spoken by my previous speaker, to the flexible. That really increases the chances of decreasing the incidence and also the mortality of CRC. And there's actually a good study from the Norway, if I'm not wrong, that told that this flexible sigmoidoscopy, when they looked at it on 64,000 patients, they did not find any difference at 7th year. But when they started to see the difference in the 11th to 12th year, basically whenever you start a screening program, the benefit is more visible in the second decade. And there was at least a 30% reduction in the CRC incidence and deaths that happened when just by doing a flexible sigmoidoscopy and repeating the sigmoidoscope after 3 to 5 years. So that's the catch. So if I come down to the next part, the non-invasive, the CT colonography is picking up. That's a virtual colonoscopy that is told. It is once in every 5 years. But the most important is when you do it, you probably would miss the lower, smaller polyps that are less than 5 millimeters. So that is why the recommendation is to repeat a virtual colonoscopy once every 5 years. The others, fecal occult blood, the FIT, and the stool DNA test, some of the part was spoken. But if you do a fecal occult blood, the screening is thrice a year, and then you repeat once a year or once in 2 years. That would be as per the recommendations. But the the FIT that really looks at is, the FIT looks into the human globulin. So it looks at very specifically, there are very few false positive. The fecal occult blood test, which is normally done, can have a lot of false positives, could also have false negatives, especially if the bleeding is very less. You could have also false positive due to sources of blood other than human blood. So that's why FIT is little more specific, because it picks up the human globulin part. The DNA test nearly looks at the something which is a mutation which is there, which is a known mutation like a KRAS. That's what the DNA test really looks at. So if you rank it across, the consensus is the colonoscopy every 10 years and the annual fecal immunochemical test, that's a FIT test, fits into tier 1, which has the maximum evidence and probably has the maximum pickup rate and is probably more acceptable. The tier 2 would be a virtual colonoscopy because people like not to have a scope inserted inside the body. You could also do the other DNA test like it is told, the FIT fecal DNA every 3 years, the flexible colonoscopy every 10 years, not every 5 years. That's a tier 2 because you are doing increasing the frequency of the scopes and probably not doing it the ideal way of 3 to 5 years. The tier 3 evidence as per the American guidelines is for a capsule colonoscopy or an available test that's not recommended, but there is a new consensus going on. If there is a SEPT9, the septin9, if it is methylated, it could be used for screening purpose, specifically for those patients who are not ready to do any of the above. So that also is now coming up. When should I discontinue? Age of 75 years or older, or if they are at those above 85, but 75 older is those when you feel that the average lifespan is not going to exceed beyond 10 years. This category, my focus will be on those who are very, very high risk, non-familial. And if I go to that part of it, IBD is one of the major source. And if you look, and when should we start screening? You start screening after 8 years of symptom onset, not diagnosis, symptom onset. That's what the recommendation is. With the history of primary sclerosing cholangitis with the IBD or a family history of CRC, you need to start even before the 8 years. And they have told that you need to biopsy at 10 centimeters gap, and approximately you need to take 32 samples if you do it the right way. So this is, if you're not doing, then in pancolitis, in IBD, you probably would not be serving the purpose of doing a screening program. The second thing which is very less spoken, when you go through literature, there's a very nice review article that's come out, is cystic fibrosis. Patients who have had cystic fibrosis, because now with treatment they're living longer, you are getting a standardized incidence ratio. SIR means those which you get a chance of getting the disease in the affected person versus the general population. And if you look at it, the SIR for colon cancer, rectal cancer, colon cancer is around 6.2 for non-transplanted, and if you go for a transplant, it's around 30. So that is the chance of getting colorectal cancer for cystic fibrosis. For patients who have survived childhood cancers because of the chemotherapeutic agents that has gone in, and because of the disruption of the GI system that happens, they also have a SIR which is higher than the general population to a tune of 4.2 to 10.9. And if they receive radiotherapy, these children's, their incidence of developing colorectal cancer again grows up. Again, coming to adults, the risk definitely grows up if there is a cervical cancer, particularly if there are young patients who have been irradiated for CS cervix. You should be very, very careful. The risk of colorectal cancer is higher than the general population. It is also associated with prostate cancer and ovarian cancer, but the tune is little lesser. For the non-alcohol liver disease, especially the studies has come from the Asian countries, mainly the East Asians, and they have found that there is probably association of more CRCs if the patient has non-alcoholic fatty liver disease. That is something that's evolving. So basically what I mean to say in this presentation is the high risk population, although is defined definitely, but newer high risk populations are going to be there, which are going to be added on. So if there is a cystic fibrosis, you need to start the colonoscopy at 40 years without a transplant, and if transplanted, around 30 years, within 2 years of transplant, and you do need to do the screening intervals in 5 or 3 yearly, depending upon whether you identify a polyp or you don't. And to if I miss that, in a sigmoidoscopy or colonoscopy, you act if there is any polyp beyond 5 millimeters. That's something very, very important. For survivors of childhood cancers, you need to probably start the colonoscopy, and 5 years if colonoscopy is used, and 3 years if multi-target stool DNA test is used. For acromegaly, even they found higher risk of colorectal cancer. IBD I've already spoken. So this is something which I felt was something which is normally not discussed. The cystic fibrosis, the transplanted cystic fibrosis, childhood cancers, which most of us do deal on the long term, the patients of gynec malignancies which have been irradiated specifically, The acromegaly patients, which most of us do not encounter, they are also at high risk. How do I prevent is one of my talk part of it. So if I need to look at the high risk patients, how do I prevent? We heard Dr. Shailesh speak about the aspirin. Look at the lifestyle and dietary, physical activity of any form. Let it be recreational. Let it be a rigorous exercise which we need to do in the gym. Let it be anything that we want to do, a routine thing, does decrease the chances of CRC. Obesity definitely increases the chances of CRC. Fruits, vegetables decrease the risk. That is, I'm quoting from the NCCN 2021. Smoking cessation is something that's very, very important. Patients who do smoke, and there has been a prospective study actually in the cancer prevention study 2, and they found on more than 30 years when they followed up 11.84 lakhs, nearly 12 lakhs population, and they found that the smokers had more risk of developing a CRC than non-smokers, more so in females. The relative risk was 1.41 versus 1.32 in males. So this is something very important. And once the person gives out away smoking, after 20 years, you see that thing also resolving back, 10 years, sorry. And the smoking of beyond 20 years is a high risk factor. And if you look at, go down to the nutrients, the red meat and processed meat are something people feel are associated with more CRCs. And the nutrient supplements probably protect you lesser than natural source nutrients. There's no data which I can quote, but that is from the NCCN 2021 again. Last important on the lifestyle is moderate to heavy alcohol use. There's a beautiful study. The meta-analysis is there from 60 odd studies, and they found the persons who are heavy drinkers, they're classified as more than 4 drinks per day, which is approximately more than 50 grams per day, versus moderate drinkers, which is 1 to 4 drinks per day, which is around 12.6 to 49.9 grams per day, or occasional, which is less than 1. If you look at it, they found the persons who are heavy drinkers have 52% more chance of getting a CRC compared to those who are light drinkers, and those who are moderate drinkers have 20% more chance of getting a CRC. So this is something. So alcohol and smoking is a total no-no. Vitamin D, if it is low, increases chance of CRC. So probably Indians with low vitamins, this is very, very significant. And I think a supplementation would be good enough. Aspirin, just to add off, that the US Preventive Task Force does tell you that aspirin reduces colorectal cancer. The risk of mortality from CRC is around 0.67, and the incidence reduces, the RR is around 0.60 if you use aspirin beyond 5 to 10 years, mind you. And who are those patients whom they felt were okay with this part? 49, 5 to 59 is the age of onset, and these patients had a cardiovascular disease risk which was more than equal to 10% at 10 years. So you do not start aspirin on that way as per the guidelines. If you have a cardiac risk which is high, more than 10% at 10 years, then if you start aspirin at around 45 to 59 years, you do get a reduction in colorectal cancers. And the Norwegian study even found the reduction visible after 3 years of use. But the most important, what is the specified dose? They put it around 81 grams. So I feel a 75 milligram of aspirin or probably a 150 mg would be sufficient at this point, but don't start it. As per recommendation for CRC reduction, it should be mainly for the cardiovascular disease, and then the protection ultimately comes in. So with this, I think I'm not missing a lot of it, because I would claim that I'm not a real expert in this field. If there is something, I'd love to know from the other experts in this August audience and maybe in the chat. But with that, I conclude that colorectal cancer is in the young are on a rise. Non-familial risk factors are important. All of us speak about familial. Even if you look at what Shailesh spoke about, it has been majorly familial. What I need to point out is the non-familial risk factors are not that common, but equally very, very important, because if you look at your last 100 patients, you look at maybe 10 of a patient were at a high risk for a CRC, which none of us give importance. Could have been a childhood cancer survivor, could have been someone with a gynec malignancy who would have taken radiotherapy, could have been a cystic fibrosis. I do not remember when I last saw a cystic fibrosis patient. Maybe my colleagues in Metro would be more adapted to this type of patient group. So these are patients apart from the IBD, and who would be you would be looking at, and probably patients who had a history of CRC prior, or someone with a family history. I think this is what it is all about. Colonoscopy is important. The take home is it should be a complete colonoscopy with a good bowel preparation, with the expert who knows what he or she is doing and has adequate time to do the colonoscopy. And with or without the fecal test is something that should suffice, because this is something that is normally recommended across. When should you start? I think a 45 to 50 years, depending upon what it is, but you should start at younger age for the high risk group. Virtual colonoscopy, to my mind, is in our country is not, I'm not pretty sure, because it is a complicated thing. I would love to see a radiologist who has that amount of time, gives that amount of time to report a virtual colonoscopy. Patients would prefer it, but you need to repeat it once in every 5 years, because it does not pick up the polyps which are less than 5 millimeters. So with that, I stop here and thank the organizers, especially Dr. Uma, and I thank Kabina for giving me this opportunity. Thank you.
Thank you so much, sir. We'll now move on to our next topic, our next speaker. Our next speaker is Dr. Prasad Narayan, who's a medical oncologist from Bangalore. He'll be talking on the topic screening and risk reducing strategies in people with familial history of CRC.
Good evening. This is Dr. Prasad from Bangalore. At the outset, I thank the organizers for this opportunity. So this is a different topic from the usual presentations that we do. And an important topic, which I realized once I started preparing for the same. I even had a talk with Dr. Sahu in the morning today regarding how we are going to deal with this topic actually. So we all talk about hereditary colorectal cancers. Then we all know that all hereditary colorectal cancers are not associated with any genetic syndromes. We also know about screening, risk reduction strategies in all colorectal cancers, including hereditary ones. So my job specifically is to speak about the implications of such strategies in hereditary colorectal cancer. So I know that I'm following the talk about the general screening and risk reduction guidelines. If you ask me in one line, is there any change in the risk reduction strategies? Not much actually, but definitely there are some huge changes in the understanding about screening and genetic mapping of hereditary colorectal cancers as compared to the others. So colorectal cancer, one of the higher costs of morbidity, mortality all over the world. In India also, we can see that in the recent times, the Indian registry is showing that there's an increase in the incidence of colorectal cancers. Most frequently in the elderly group, we see a lot of younger patients, as in many other cancers actually. So it is estimated that around 10% occurs in the group less than 50 years. This has implication because of the new guidelines of screening, which recommends to do screening from 45 years of age. So when we take the risk factors, my discussion will be mainly centered to the left-hand side of the screen. That is the familial and personal medical history, the genetics, family history, history of inflammatory bowel disease, colon polyps, and then something about diabetes, cholecystectomy. So we are all wanting to find out those patients who are high risk among the group, and cancer risk varies within a population. It is influenced by genetic and environmental factors. So how is the risk stratification done? For appropriate screening and surveillance, we have groups who are average risk, increased risk, high risk, and highest risk. So where does this high risk, highest risk come? That is in the suspected genetic syndromes, the FAP syndrome, HNPCC, then inflammatory bowel disease, chronic ulcerative colitis makes it high risk, and then the family history of colorectal cancers or adenomas, first degree or second degree groups. Also, history of adenomas, serrated polyps, or colorectal cancers. So this is how the risk stratification is done. And the US Preventive Task Force has got 3 grades actually of recommendation. Grade A is to screen all the adults from 50 to 75 years. The grade B, it is 45 to 49 years for colorectal cancer in some group of patients. And grade C is selectively screen adults over the age of age 76 because screening might not help. Detection will not make a difference in the overall outcome. So when we speak about screening patients with family history, the patient has to have either a colorectal cancer or adenoma. That is one of the criteria. Then it is about at what age the patient develops this, or a first degree relative develops this actually. Then it is about whether there are 2 second degree relatives with colorectal cancer or 2 or more of them. So the more criteria, once we start ticking more boxes, the recommendation to do more tests will come. So the recommendation in the first group will be to begin screening at the age of 40 with any test that is recommended for average risk. Then colonoscopy every 5 years, so on and so forth. So we will go into details of all this. How do we implement this recommendation when we say that to screen all adults from 45 to 75 years? I'm sure that we have discussed this in the previous talk. The different types of tests which are recommended, which includes the fecal occult blood test, the high sensitivity test, the fecal immunochemical test, the stool DNA, the CT colonography, flexible sigmoidoscopy, the sigmoidoscopy plus the annual FIT, colonoscopy screening at different frequent intervals, and selectively screen the adults age 75 to 85 years. What are the characteristics of each of these tests? I will not go into the details of that. I'll stick to the topic of the hereditary colorectal cancers. So when we have somebody with a family history of colorectal cancer, the key thing is to find out whether we are dealing with a Lynch syndrome or polyposis. Why is it important? Because the risk of developing cancer is very high in this group of patients, which I will come to later. Also, Lynch syndrome patients are prone to develop cancers in other sites, like the gastric cancers or the pancreatic cancers or cancers of the small bowel. So if you take all colorectal cancer patients, we may see around 30% of them having a family history, but only 5 to 10% of them can mostly have a Lynch syndrome or polyposis, but it is important to go and identify them. So once we suspect a Lynch syndrome or polyposis, the pathway is totally different. How will you suspect Lynch syndrome or polyposis? I will come to that in the next slide. So if you don't suspect a Lynch syndrome or polyposis, the general recommendation which stands true for other colorectal cancer patients holds true for the family history positive colorectal cancer patients as well. So again, we will have them into average risk, moderate risk, and high risk, and follow the recommendations as per the risk stratification. What happens when you, why are you talking about Lynch syndrome separately? Because Lynch syndrome can greatly increase a person's risk for colorectal cancer. The lifetime risk can range from about 10 to 80%, depending upon the mutation which is causing the syndrome. So what is Lynch syndrome? Lynch syndrome is caused by a pathogenic variation in the coding sequence or the regulatory domains of the mismatch repair genes, which are the MLH1, MSH2, MSH6, and PMS2. So these patients, how do we look for Lynch syndrome? When do we look for Lynch syndrome? There are two broadly followed criteria, the Amsterdam criteria and the Bethesda guidelines. One is a first degree relative, either a parent, brother, sister, or child, or at least 2 successive generations are affected. At least one relative had their cancer when they were younger than 50. If all these apply, then genetic counseling is warranted. The Bethesda guidelines say age less than 50, has or had a second colorectal cancer or another cancers related to the Lynch syndrome, or a first degree related younger than 50. And a patient has 2 or more of first or second degree relatives who have got colorectal cancer. So I don't think that we need to go into each and every criteria, but these are the broad criteria based on which we look for Lynch syndrome. And if any of these criteria are filled, then the patient should undergo an MSI testing. And familial adenomatous polyposis, the lifetime risk for developing colorectal cancer is 100% almost. So most of the time, we would identify it after the patient develops a colorectal cancer. In a retrospective manner, go and find out that this was a part of an FAP. It causes polyps and cancer earlier than the usual age. And the people who test positive for the genetic change linked to FAP should be started screening from 10 to 15 years of age, which is too much of an ask. And I don't know, I have never seen in my life any FAP, but getting a colorectal cancer screening from 10 to 15 years of age is something to discuss. I'm sure the panel discussion will take this up. So coming to the gene-specific management for Lynch syndrome, suppose you find a MMR gene mutation from doing the MSI or the DMMR test. You have to see what was the mutation which we found out, because the pathway is different for the MLH1 or MSH2 group as well as the MSH6 or PMS2 group. So the MLH1 MSH2 group, the screening should start early at the age of 25, and 2 yearly colonoscopy is recommended. And consider gene-specific management, colectomy is recommended actually. This is slightly more intense monitoring and intense treatments are recommended in this group of patients than the ones who are MSH6, PMS2. The screening starts at 35 years, and usually it is a standard management which is done in terms of the surgical treatments. So that is it about the Lynch syndrome once we diagnose it. What about Lynch-like syndrome? Why is it important to find them? So Lynch-like syndrome is something which I was not much aware before I prepared for this talk. So the interesting thing is that when you take all the MSI, the DMMR group in colorectal cancer patients, when we find out 59% of them are actually Lynch-like syndrome. So it is a significant group of patients with who will have a deficient MMR. So these are a subgroup of patients who have got a DMMR, but it is not explained by any of those detectable variants which we usually see in the MMR genes, the 4 usual suspects which we do. It cannot be explained by the change in an EpCAM gene or BRAF. So basically, this is something which is unexplainable why the patient has got a DMMR. And it could be because of a somatic variant actually. If that somatic variant is identified, then the patient is actually treated like a non-Lynch syndrome. So if you detect these double somatic mutations, and that is the cause of the Lynch-like syndrome or the DMMR in this group of patients, they will be followed up like any other familial colorectal cancer patient, not like Lynch syndrome. But if you don't identify any reason for this DMMR, then the group should be, that proband and the group should be, first degree relatives should be treated or followed up like Lynch syndrome, which means more extensive regular follow-ups, every 2-year surveillance, and even the surgical treatments which are done are different. And there is possibility of developing Lynch syndrome related cancers in this group. So that is the importance of identifying the Lynch-like syndrome. And as per the present data, 59% of the patients whom we may think is a Lynch syndrome could be a Lynch-like syndrome. So this chart actually shows the molecular testing strategies. So almost all patients, regardless of family history, will get a DMMR test done now. So I will not talk about those two. There is a group called early onset colorectal cancer, which is diagnosed less than 30 years of age without having a HNPCC or a Lynch syndrome or a familial adenomatous polyposis. Those patients also, there's a recommendation to do a full gene panel to find out whether we are missing anything. The Lynch-like syndrome I already explained. There is a group called Serrated polyposis syndrome. This is basically a diagnosis of exclusion, and it is mostly a phenotypic diagnosis more than a genetic diagnosis. Then multiple colorectal adenomas is also another entity actually, where there are a specific number of adenomas with different age groups is described. There's a gene panel testing recommended for them also. As a take home, I think the Lynch syndrome, Lynch-like syndrome, familial adenomatous polyposis, these are the 3 where we should be focusing on. Now, doing all this, what are the benefits? what will we gain by this screening technique? So there are benefits which are described in terms of additional life years gained, as well as how many deaths can be averted. So we can be there can be a debate on whether it is worth it or not, that about the life years gained versus the deaths which are averted. But definitely, if you have a screening test and we can find out an early cancer, the outcomes are better. And awareness on that is very important not only among the public, about the treating oncologists as well. Are there any harms of colorectal cancer screening? Mainly the issues are bleeding and perforation, not in very high percentages. Some electrolyte imbalance and nephropathy from the bowel preparations, cardiopulmonary events from moderate or deep sedation. These are all the things, but very, very uncommon actually. The main thing is to undergo the test, which definitely is an emotional thing to go through. If you are asked to get a colonoscopy done once every 2 years, it is not easy to go through. Now we come to the risk reduction strategies. There are many which are suggested, but which have been tried, but very less which have got strong evidence. So the US Preventive Task Force actually recommends aspirin. There's a statement on that. That is recommended by most of the societies. A diet low in animal fats, increase the fruits, vegetables, whole grains. Also decrease the risk by increasing physical activity, limiting alcohol and tobacco. So I will come to that. So cholesterol and fat intake, evidence is based on meta-analysis, randomized controlled trial, twofold increase in the risk. Coffee consumption, conflicting evidence. We can have coffee. We can't say whether there is any great evidence against or for it. Dairy intakes, there is a 15% reduced risk with more than 8 ounces of cow's milk per day. Fiber intake definitely helps. Red meat intake should be reduced. Good solid evidence of alcohol and cigarette smoking increasing the risk. Then obesity and physical activity. About medications, aspirin, there were 3 randomized trials. Review of them showed that there's a 40% reduced risk of colorectal cancer. This, since my topic was in hereditary group, this is applicable to the hereditary group as well. That's why I'm showing the slide. Calcium, also there is a Cochrane review and meta-analysis which shows that there's a 26% reduced risk of adenomatous polyp and 22% reduced risk of colorectal cancers. The data on antioxidants, cyclooxygenase 2 inhibitors, folic acid, hormones, etc., not much actually. So that is my 10 or 12 minutes of talk. If I can summarize this by saying that it is important to identify the family history, which will be present in almost 1/3 of the patients with colorectal cancer, of which a very small percent of them could be the Lynch syndrome or the FAP syndrome, which we have to identify. Among the Lynch syndrome patients, it's important to know that there is something called as a Lynch-Like Syndrome as well. There are genetic tests which help us in identifying them, whether they will translate into any treatment outcome. At this point of time, we can say that it's more in surveillance. The risk reduction strategies are still evolving, but awareness about the same among the oncology community will definitely help. Thank you.
Thank you so much, sir. We'll now move on to our expert comments. It gives me great pleasure to introduce our chairperson and expert, who's none other than Dr. Govind Babu, medical oncologist from Bangalore. Sir, can I request you to please give your comments and also moderate the Q&A? Over to you, sir.
Thank you, Kashish, and thanks for this opportunity, Dr. Uma. It's been a wonderful session to start off with. As Dr. Sahu said, these are topics that we don't give too much importance to, but I think it's becoming important because we are seeing more and more of this population now with the awareness that has increased. So these 3 talks were really excellent, and the questions that I saw was somebody, I think Dr. Viraj, asking about the role of coffee in colorectal cancer. I think Dr. Prasad actually mentioned it, that it's controversial. But some years ago, there was actually a conference on health and coffee organized by the Indian Coffee Board. And they really showed a lot of data to show that it does prevent. And some of the theories that were put forth by these papers was that it increases the motility of the gut, it increases the gallbladder emptying time, and therefore decreases the transit time of many of the carcinogens that are present in the gut. So that was one of the important ones. But what they said was it was about 4 to 5 cups of coffee per day, which was beneficial. But as Prasad said, there is still a lot of controversy that exists, but it is not harmful like alcohol or tobacco use. So that's a good thing to remember. And I saw the other question was about role of immunotherapy in adjuvant setting in colorectal cancer in those with Lynch syndrome. I think as of now, there is no approval for this in the adjuvant setting. Dr. Sahu or Dr. Prasad, any thoughts on this particular question?
So regarding the treatment, right, with immunotherapy?
Yes, that's right.
I think you answered. I saw it in the chat.
Yeah, but if you have anything else, I'm not too sure.
No, I think Viraj and you, sir, rightly pointed out both the things.
Okay, okay. Kashish, any other questions? These are the only two I saw.
So these are the two we've received.
Yeah, that's right.
So what we can do is, so we can go to the panel discussion and then we can go to your chairperson comments.
Sure.
Perfect.
Thanks.
So thank you so much, Govind sir. We'll move on to the next part of the discussion, that is the panel discussion. The panel discussion will be on hereditary colorectal cancer. And our moderator is Dr. M. Vamshi Krishna, who is a medical oncologist from Hyderabad. His panelists are Dr. Anand Ramaswamy, medical oncologist from Mumbai, Dr. Viraj Lavingya, medical oncologist from Ahmedabad, Dr. Bharat Singh Bhosle, medical oncologist from Mumbai, Dr. Sandeep Goyal, medical oncologist from Mumbai, Dr. Tejinder Singh, medical oncologist from Mumbai, and Dr. M.V. Chandrakant, medical oncologist from Kolkata. So over to you, Vamshi sir.
Good evening, everyone. As usual, the previous speakers have done such a great job. There's not much for me to talk on. What I will do is I'll just go through a few of the cases that we have seen in our institute. I'll find out what we are doing and then, what everyone does. As always, what we do is not perfect. There's always room for improvement as for everyone. Requesting all the panelists to be concise and precise as usual. We have Dr. Anand, Dr. Viraj, Dr. Bharat, Dr. Sandeep Goyale, Dr. Tejinder, and Dr. Chandrakant. So we just go with the cases one by one. This was a patient who was a 47-year-old gentleman, presented only with weakness and fatigability, found to have a cecal mass. Surgery done, T1N0. Now, this was the report. As you can see, it's a right hemicolectomy, ulceroproliferative growth, 4 into 5 centimeter, adenoCA moderately differentiated, T3, it was T3 and N0 with 28 nodes positive, no actually other risk factors present. So, Dr. Viraj, what would you like to do?
So I didn't see LVI or PNI features in that report. So that would be recommended. And we do MMR testing by IHC to look for whether this gentleman needs an adjuvant chemo or not.
Very good. So, Dr. Anand, do you agree with that?
Yeah, I agree with that. Fair enough. I think
okay.
Everyone else is required, pointed.
Oh, that's fine. I mean, I'm just asking. So, Dr. Chandrakant, if I can ask you, 47-year-old, does that ring a bell for you? Does that give you a reason to do MMR beyond just treating?
Yeah, definitely. I think for treatment, it is not required for this patient.
Okay. So,
because T1 anyways, we will observe.
Mm-hmm.
So, I would do an MSI in the somatic. And of course, I would also do a germline MMR.
Okay, so you're going to do germline MMR for anybody. What is your indication for doing germline MMR? Viraj very vehemently disagrees with you. I will get back to Viraj later.
If I have a MSI on the somatic MSI positivity.
So doing the reflex testing with a somatic MSI and followed by MMR is different. You said MMR on germline. So would you do it in every case? Is what
No, not in every case.
Not in every case. Okay, very good. Dr. Sandeep, we are here clinicians here. None of us are molecular geneticists. This patient, based on just 47 years, would you want to do MSI? Would you want to do MSI based for your treatment? Because remember, T3, no risk factor, you make a case for just observation alone, irrespective of the MSI.
So I think in this patient, you need for two reasons. One is because T3N0, whether you want to
I have
give
not done
adjuvant
it. I have
treatment
just
or
said
not.
that this is the patient. I am asking you what you will do.
That's what I'm saying. We would do it for two reasons. One, we would do it for adjuvant therapy needed or not. And secondly, because he's less than 50 years of age, then to know any hereditary risk factor, we would do it for that as well.
Okay. Dr. Bharat, when do you start evaluating for any of these and doing an MSI from the point of view of genetics? What's your cutoff? 50 years, 55, 60, 50 with family history? What do you take it as?
So for my practice, it's not based on the guidelines. I take it 50 as a cutoff.
All patients, irrespective of family history?
Yes.
Okay, very good. Dr. Tejinder, what do you do?
No, I think what Bharat is telling is what I follow also.
Okay.
Similar to.
Okay. Anand, TMH, what will be your policy? Send everyone as a matter of research, or would you want to use this cutoff of 50 or 60 with family history? What's your cutoff?
So we do send patients under 50 for at least genetic counseling and, get a whole pedigree done for sure. Yes. And then, of course, the MSI helps. The MMR or MSI helps.
Okay. So only less than 50, you will send all patients for genetic counseling, if I understand you correctly. That seems to be the consensus. Dr. Bharat, we are, general practitioners outside of TMH. Do you actually send everybody like this, or is it more for what we intend to do?
No, Vamshi, everybody is aware, and see, it is not today. I have 3 patients seen before 2013 and had mentioned in my discussion to them about the genetic counseling and then genetic testing. None of them have done. And unfortunately, the second generation had developed in 2 of them, and they are now in treatment with me. And I had mentioned on my old papers, that you need genetic counseling and see a genetic counselor. Okay. It is more evolved now and better. We also counsel in a better way than a counselor today. But 7 or 8 years back, this field was not that evolved, which is developed today. So we have access to counselors right and left today, at least in metros.
Okay. Dr. Chandrakant, Calcutta, do you have access to genetic counselors as easily as Dr. Bharat says?
So counselors, it's very difficult. We had some professional counselors.
Okay.
But the patient is more confused after hearing the counseling. So the MedGenome has their own counselor.
True.
Okay. So let's not name names. Okay, I get your point. So to be honest, in Hyderabad, I have nobody till now.
Yeah.
Actually, we have just appointed a medical geneticist to our hospital today. So, it's a point well taken that probably metros, Delhi and Bombay, yes, we don't have anybody from anywhere else, but I am not sure in tier 2, we can definitely claim to have this. And even though, yes, you have somebody who is an online person, I'm not sure. Viraj, Ahmedabad, do you have somebody, or is it somebody from these labs who will do an online consult?
No, we have in-house genetic counselor.
Fantastic.
So just going back to your question, first, all patients of CRC gets an MMR testing, number 1.
Okay.
And like Dr. Anand said, all below 50 goes for a genetic counseling.
Okay.
If patient does not have a polyposis, I don't know how much going behind for a germline testing helps them.
Well, okay.
So that's our policy.
Okay. So can I ask you, Viraj, since you introduced this point, what about if a patient has a T3N2 disease? We are very comfortable giving chemotherapy to that patient. We don't do an MSI normally. There's no requirement of doing MSI for any treatment for a N+ disease.
Correct.
Would you still do it just
as of today? Yes. But yes, for genetic testing, we do it for all.
All patients.
All patients. All.
Okay. Anant is very impressed by that fact. Anant, I take it that in your place, are you doing it for all patients? N+ 58-year-old guy.
Like ERPR, HER2 for breast. So
okay, great.
Right?
Doing it is fantastic.
Yeah.
Anant.
So I think in May 2020, I think NCCN said that, do MSI for stage 3 also. Now, don't ask me the rationale behind it. I'm not completely sure because it's not going to change my treatment, but they did say it. So, for what it's worth.
So are you doing it?
No.
You are not
I
doing
don't see the sense behind it.
Viraj, I'll get back to you. Dr. Bharat, this is the same question. Supposing this guy was N+, 48, let's say 52-year-old, will you do a testing for such patients? Or would you look at history, family history, and then do the testing only?
Yeah, so as a rule, the family history is very much priority in today's date. And if there is a slight suspicion of some close relative, because see, the practicality in our country, people will tell you there was some tumor operated somewhere, Tata or non-Tata, like that. This is suspicious history which should raise us no alarm, and you should counsel them for genetic counseling.
Okay, great. Chandrakant, do you agree with this? We will test based on the family history if it is a node positive or something else. Because again, if it's a metastatic, the tendency is to just go ahead with the treatment. We kind of ignore the MSI testing unless it's, the family history is strongly positive. Do you agree with that? Or are we now evolving to a place where everybody should be tested?
Correct. So I think by biology, MSI high doesn't usually have a node metastasis. So it's usually a locally confined, non-metastatic sort of a thing. So that's the reason why probably the number of patients having a MSI high node positive is very unlikely, and that's why the recommendations are not that great in this setting. So in a node positive patient, I don't do an MSI routinely unless there is a strong family history.
Okay, I don't agree with that because the numbers are decreasing. You have around 25% to 20 to 25% in stage 1, around 15 to 20 in stage 2. In stage 3, it comes down to 10. In stage 4, it comes down to 5. So the percentage reduces, but certainly it is there as a percentage, right? Anyone can correct me if the exact numbers are wrong. It's off by around 5-10% probably.
Exactly.
Okay. Yes.
In fact, in a couple of years, so there are 2 randomized phase 3 trials of adjuvant immunotherapy. Somebody asked. And they are all for stage 3. So there is almost 10 to 12% who are stage 3 MSI high.
Oh, yes. Dr. Tejinder, MSI testing, as a PG student, there's always a huge problem to understand what you're talking of. Are you talking of MSI expression? Are we talking of loss of MMR? That's how it is reported. So are we okay with the interpretation by now over the era?
I think it's still confusion for us when you sit suddenly, suddenly somebody comes in the stage 2 and you've done a MSI, then you start again, want to revisit and think about it. So I think it's in the practical point, the question which you asked previously was that whether we do it for everyone. I don't, in a private practice, I don't do it for everyone. But I think the trend might change with nowadays with so much of new things coming over there. So I do agree with Viraj that future, I do not know where we are going ahead, but yes, it might change. So for me to interpret MSI, it becomes like very confusing thing suddenly, honestly.
Okay, I appreciate your honesty because frankly, I think if we catch hold of 50 medical oncologists across the place, not from TMH and not Viraj, probably we'll get a similar result. Most of us will be confused because the patients, the reports are actually in different areas. They say loss of this protein indicates loss, not presence of MSS or something like that. And then we say, what is MSS? What is MSI? It's kind of confusing. We need to look at the report. Great. So this patient actually had a loss of expression of MSH2 and MSH6 on IHC. Okay. So Dr. Bharat, loss of expression of these two, would that be something that raises your alarm bells or what are the categories that you look at?
So at least 2, that is what at least 2 has to be there to say it is a deficient MMR, and then you can take it as a deficient or you can go with the PCR in this thing.
Perfect. So Dr. Anand, such a patient comes to you, loss of MSH2, MSH6. You would want to do a PCR for this patient, do the genetic counseling later on. What if only one was lost? Would you still do it?
So the correlation now, MLH1 and PMS2, MSH2, MSH6 are codependency, they go together. So, and the correlation between IHC, which is much cheaper, and PCR is excellent. It's almost 95 to 98%. So I would be okay with this report to send this patient for further genetic testing, counseling, and
Okay. Viraj, NCCN tells you when to do what, when it is. I will never for my life remember this. Is it something that you have practiced or you just stick it up somewhere and then look at it and go for it? Or
no one can remember that, Dr. Vamshi. No one can.
No one remembers this.
No one remembers.
Important point I wanted to make, it's very important for MMR, and Anand can correct me if I'm wrong. Like he said, MLH1 and PMS2 goes hand in hand. The problem with PMS2, it's a very fragile protein. And you often see a solitary loss of PMS2 and you jump out of the chair and say, hey, it's MSI high.
Correct.
And it is a big problem when you label these patients as MSI high and you have to actually do a PCR on tissue block. to confirm whether this is MSI high. So only PMS2, be very, very careful. You can still have MSI high, but because of the very fragile protein, we need to confirm that. That's an important point.
And also you have the MLH1 PMS2 correlation, and then you're supposed to look at the BRAF and then say if BRAF is positive and then go by it. So that's what it is. And this is, I just put up to show that it is not as simple as we sometimes see. Now, coming back to this patient.
I think Vamsi, you should have one question. How many of us send it to a genetic counselor? It's more important.
I'm bringing that question. Okay. So since you have introduced it, let's do it. Dr. Anand, you have this patient. I think you will send it because you have a genetics department next to you. So I'll not ask you. Viraj has a person in his hospital, so he will send it to them. Dr. Chandrakant?
Of course, I also was supposed to send, but unfortunately the prospect is not there. So if there is MSI high, I would stress on the PCR followed by a germline testing. Why not?
So basically it is something that you will do. You will do the MSI by yourself, you will do the PCR by yourself, and then you will try to explain to the patient. Fair enough. I mean, that's what even I was doing most of the time because we don't have it, and I quietly try to send them off to some genetic counselor somewhere in another institute because we don't have the people at hand. That's what we do. Bharat, what is your practice? You have more access to counselor.
Yeah, so access to counselor nowadays, no counseling can be done by telemedicine because we are also doing the same thing here. Okay. And the core, be it Delhi-based lab like a core diagnostic or something like a Hyderabad-based strand or some Bangalore-based lab, they have their in-house genetic counselors who are doing this job. And I would not say the 100% patient satisfaction is there. They confuse sometimes and they come back to us. So we have to be involved in the discussion rather than sending the patient to a genetic counselor.
Very good. I completely agree with you. We cannot just send to the counselor and forget about it. We need to be involved in the follow-up. Excellent. So this patient, what happened was, for whatever reason, T3N0, but no risk factors, treated with capecitabine single agent. Counseling was not done. Patient presented 8 months later with abdominal pain and hematuria, was found to have a renal mass. Surgery done, found to have an RCC, clear cell carcinoma. So with this, would you insist on doing a genetic counseling? I think everyone says yes. I think that's a given. We should do a genetic counseling. So Dr. Tejinder, again, bringing the same point, who will do counseling in your practice? Should it be the clinician? Should it be the genetic counselor? Should it be a mixture of both? So I think this question has been answered by all of you. It should be a mixture of both. We should send to a qualified geneticist, but at the same time, patients should also be in touch with us. Correct? Dr. Viraj, I agree? Agree. And how do you test for this patient? You can take this. Would you do a panel test? Would you do a whole exome sequencing, or would you leave it to the geneticist to decide?
So we do panel testing. We don't do whole exome sequencing.
Do you do whole hotspot or do you do complete sequence?
So complete sequencing.
Complete sequencing. Anand?
Yeah, same.
Same. Okay. Dr. Chandrakant, patient comes to you. You said you have less access. You would be doing the PCR on your own. Would you order the panel or would you order the whole exome sequencing?
So I think we have something called Hereditary Cancer Panel Hotspot.
Correct.
That is what is more practical and less, it's more economical than exome. I am not aware of this exome sequencing. I am seeing for the first time.
Okay. Anand, exome or panel?
I think the panel tests the whole thing. It is not only going to pick up your
the commercial one is mostly hotspot. The commercial one is mostly hotspot. The lab one,
I think they give you the options of whether you want to look at a hotspot or whether you want to look at whole exome or the panel. Mostly, if you do even the hotspots, I think 95 or 90% are covered. So it is a practical answer. I mean, and it's beneficial in terms of costs.
Fair enough. So this is this patient's line.
Can I make a comment? For the hotspot, it's just my personal experience that many a times, you have an MMR deficiency on IHC and your germline report comes back and says it's a VUS. So it's a hell of a problem there. So I think a better testing is more warranted.
Okay. Dr. Sandeep Goyal, sir, you are there. I'm sorry. I think I skipped you in this discussion. So sorry for that. What's your take on this? When would you do a testing and your take on this genetic counseling?
So, this patient definitely has got two cancers in such a short period of time. So I would refer to my genetic counselor, right? And, I think we have a advantage of having a genetic counselor both in our hospital and we also refer to TMH. So that's what I would do.
Perfect. So I think the conclusion is for genetics, please relocate to Mumbai. You can get a lot of counselors there. That seems to be the message going out from our panel. So this is the patient actually who had a family tree made. This is by the medical genetist. Anyone who knows me will know this is not such neatness is not in my handwriting. So this was made by the medical genetist, and we did a whole exome sequencing. Now, again, this was done at CCMB, that is one of the centers of molecular biology excellence in India. And this was the report that was given. A patient had a gene transcript of MSH2, and this is known as the Muir-Torre syndrome. So it is one of the syndromes of the familial hereditary HNPCC, and the patient had a HNPCC positive. So this was this patient, right? Second patient. Now this case was a 28-year-old gentleman, came with bleeding PR, weight loss. Maternal uncle only died of throat cancer. Investigated, found to have a growth, moderately differentiated adenocarcinoma, sigmoid colectomy done, a T3, again N0 with no other risk factors, but there was one more adenoma with a high-grade dysplasia. So again, Dr. Chandrakant, would you want to do MSI in this patient based on the other adenoma test? Would you think it's a high risk for cancer because of the young age? Would you evaluate along those lines?
So one, yes, definitely this patient needs further evaluation. I think the whole complete colonoscopy, we need to look into other any polyps.
Colonoscopy was done completely, no polyps.
And then I would of course look for APC and all this. I think this is there's polyposis in this, right?
No, there was no polyposis. There was a single rectal adenoma which came as high-grade dysplasia, and there was a single tumor.
I think I would send for the. I would consider this as a high risk for genetic, and I would further investigate for further genetic tests.
So, Dr. Bharat, if I can ask you, do you think the MSI is the best screening because it only looks at Lynch? You know, when you have FAP, when you have all the STK, you have a mutor-like thing before, you have so many other genes. When you have a risk, when you have a suspicion with a family history, should you even do the MSI? Shouldn't we directly do a PCR and look for the mutants or a panel?
Yeah, I agree with you. If we have a strong history and strong clinical suspicion of a particular syndrome, rather than doing no stepwise testing, I would rather go with the broad testing. But Dr. no, Sandeep, we are evolving. So we are evolving in terms of our approach, and that is what we traditionally got. It is very difficult to break our traditional habit. So maybe next year we'll be discussing which panel rather than discussing the IHC straight away.
Fantastic.
But no, it's all dynamic field, and at present I would be not comfortable directly going to. But yes, if there is a strong history, rather than wasting time, I would do a directly more comprehensive. See, that gives you a banking the result, because most of these patients, high risk patients, come up in the future with the metastatic setting. You have the whole of the information available with you.
Dr.
So that is also
Go ahead, Bharat.
Yeah. So that is what the point. But at this moment, it's better to do a reflex testing rather than going ahead with the.
Perfect. Dr. Goyle, what's your thoughts about it? Would you send any patient where you have some suspicion, send it to the geneticist, look for any mutation?
Yes, in fact, this patient has got a high risk, so definitely I would send and do the testing.
Excellent. So again, the idea being that you look at not just the MSI, try to look if the patient is fitting into other criteria. So in this context, Dr. Anand, would you look at the Bethesda? Do you look at the NIH criteria in clinical practice? I mean, seeing 50 patients in OPD, would you have these in the back of your head?
So I actually like the Amsterdam 2 criteria because it's easy to remember. 3, 2, 1.
Right.
3 first, 2 generations, 1 more than 50. So reflexly, I do ask for family history, and even if one of them strikes, I would not hesitate to send. I mean,
so how important is age for you? Because see, Amsterdam and all are okay for genetic syndrome, but sometimes even a sporadic might come, and then you need to look for it. Would you just deny on that? Would you go for it?
There are 2 things to this. One, in India, available data says our colorectal cancers are anyway younger than the quoted 60 to 70 in the West. 1. 2, there is more data to say they are probably a separate cohort which is doing worse off, especially the rectal cancers, which are more common here. So I would like all the information for this patient before treating them, one of which is, a hereditary thought process also. So, yeah.
Right.
So Vamshi, doing obviously in case-to-case basis, we can send for the broader panel. But sir has already mentioned, sometimes we get so many mutations, and then what to do with that is and Anant has also said the same thing. So you have to take case-based discussion, case-to-case basis. You have to decide rather than making it a generalized statement to send it for all patients. So a lot of information comes, and then we are stuck with what to do. The good thing is that with the years passing, at least these labs are sending reports in less number of papers. Otherwise, initially they used to send a big book, and I used to keep it aside and call the geneticist and please, you only explain me and the patient this report. So in that front, we are at least evolving. Spend less time, because the oncologist busy like you will not be able to read the entire report.
So, I mean, my solution to that is very simple: start specializing and see less patients. So, I don't think any of us would like to do that, but I think practically that's the only way we can handle this kind of complicated cases. So, third case is again a 35-year-old male, no family history, though his uncle had some colonic malignancy. Like Chandrakant says, we don't know what malignancy, some kind of tumor they might have had. This patient now had multiple sessile pedunculated polyps seen. They were seen in the rectum, they are seen in the sigmoid. Scope could not be negotiated away from it. Biopsies taken, one of them came as an adenocarcinoma. So, Chandrakant, your situation in this scenario, what would you suggest? You're having a report which says that there are multiple polyps. One of them is an adeno-CA. What would you advise?
I think this patient has a adenomatous polyposis, I think. And if at all, if a surgery is needed, he will need a total colectomy. So I think we need to anticipate before surgery itself. I need to see whether it is FAP or not. And similar in Lynch syndrome. So where a patient has MSI high, only sigmoid colon removed. So now should I go ahead and do a total colectomy is what the patient comes and asks. So these are difficult questions to answer. Right. And it is very good if I decide what it is before I go to the definitive.
That's the question I have put there. Who decides the surgery? Is it the surgeon who cuts and sends to you, or is it the MDT done beforehand? Dr. Sandeep, your practice, do you think it is discussed?
So in our practice, most of the times it's the surgeon who decide, because they don't come to us upfront. And but if there's a intelligent surgeon who wants to discuss, then it's a mutual decision. But most of the times I would say it's a surgeon's call.
Dr. Tejinder, this scenario, like what he was, or Chandrakant was referring to, patient comes with only a sigmoid colectomy. Let's assume this patient undergoes only a rectal and sigmoid because of the adeno-CA. Of course, it makes things easier here, but supposing he had only polyps and he gets a sigmoid, and then the patient comes to you and you say, now you do a proctocolectomy. So how is it in your practice?
Mostly, like what Sandeep said, is my practice same. Most of the time they come after the surgery. But if suppose a patient has undergone a sigmoid only a hemicolectomy, then naturally I will advise the patient to reconsider for the total colectomy. But honestly, most of the patients which I am getting is total.
So Dr. Viraj and then Dr. Anand, the genetic counseling pre-surgery for such a patient with a lot of polyps, would you do that? Do you do that in your practice?
Yes.
Ideally, yes, you should do it. But is it happening in reality?
So I agree with Dr. Sandeep that sometimes these patients come after the surgery, but we also had patients coming before surgery. Why I'll tell you, because it depends on how many polyps did you see. Let's say you saw only in that segment 200 polyps, then we know we're dealing like FAP-like. But let's say you had 10-20 polyps, then he need not necessarily go for total proctocolectomy, and we may still preserve, because he's still young. It's not good to give him stoma for life. And we can still do screening, because you can have attenuated FAP or MUTY associated. So I would definitely want a APC germline before this, before going for surgery.
Fantastic. Dr. Bharat, patient comes to you, you manage to keep your surgeon from cutting him. You say that let's do counseling, let's do thing, and you don't find an APC mutation. The reason could be it's a variant APC, it could be a attenuated APC, it could have been some other genes which are involved which you have not tested for. Would you still want to go for a full surgery, or would you say just do a small surgery?
See, so for if I don't have any conclusive evidence that it is fitting into the syndrome, still with this kind of a high risk patients, younger patients, they tend to recur, or it will be very difficult to convince the patient. It is not like breast cancer where the patient herself comes and remove the entire breast, and their surgeon counsels for the conservative surgery. Here we are exactly opposite. Patient, first of all, patient is not going to accept to remove the entire colon. You need extensive counseling. The surgeon, yourself, and the geneticist has to sit together. So it's very difficult. It's counseling and getting patient ready for the surgery is a difficult thing. Obviously, if at the end of the counseling, if the patient agrees for the entire removing the entire colon, that is the best in the interest of the patient's outcome.
Fantastic. So Kashish, how much time do we have? A minute or two, I guess, from my thing, or do I have more time?
Yes, a minute or two, sir.
Minute or two. Okay, very good. So anyway, my surgeon was very probably more aggressive. So they basically did a complete this thing. They had a intraoperative colonoscopy also. They found multiple this. So they did total proctocolectomy, and that showed T1N0. Okay, PTN0 with T1 disease. So in such patients, Dr. Anand, let's assume it's a FAP. What next? How would you give chemotherapy? How do you follow up the patients?
Yeah, I think, I mean, T1N0, you would not consider chemotherapy.
So the chemotherapy principle remains the same for non-FAP versus FAP, or is there any difference?
No,
Supposing the node positive, you would give the same chemo. Is that correct?
Yes. I mean, you treat it as it is. The one thing that, I mean, the few patients that we've seen, and this is only personal experience, if, for example, it was a rectal predominant cancer, they do have more complications when you're treating them with RT and oral capecitabine or even 5-FU. That is one thing.
Very soft. I'm not really hearing.
Yeah, so they do have, an increased risk of toxicities when you treat them, but otherwise the principles I think remain the same.
I mean, Dr. Sandeep, how would you follow these patients post surgery?
Well, regular, I don't know what will be screening here because you have taken the whole colon out.
Exactly.
But then you would obviously follow up for any metastasis, although the risk will be less because T1N0. And you would obviously definitely screen the other members.
Wonderful. So this is my summary. So most important is we need to look for these symptoms. They will not come and jump out at us. We need to be more aggressive looking for it. We need a good molecular genesis, need a good molecular clinic. Most importantly, a MDT management. Counseling, and more counseling. That is the essential thing. So if any other panelists have anything to share, otherwise I will close here.
So, Dr. Vamshi, I had one final comment. So as you said, if the genetic test came as there is no identifiable gene that is actually responsible, but still the patient has a strong family history, then I think still we would consider it as high risk and go ahead for a high risk counseling.
Okay, fine. Okay then, so thank you all again. As usual, panelists has been great. It's been an interesting topic, and again, more we present these, more we start looking for it, because that's when we read. So that's been my experience. So thank you everyone, and over to the organizers.
Thank you so much, sir. And now I request the chairperson to please give his comments. Over to you, sir. Over to you, go on, sir.
Thank you, Kashish. I think we've had a wonderful panel discussion also, and most of the questions have been answered. There is one question here from Dr. Uma. She says, even after ileal pouch, is endoscopy recommended? Risk of recurrence of the polyp at an endoscopic site. Who would like to take this? Vamshi?
Sir, I'm not very sure about this answer, to be honest, because I really don't know, to be honest.
Let's ask Anant if he has any experience on this at TMH.
I mean, once you've done a complete this one, there is no role of any, and there is some data for this. They've actually looked at the anastomotic sites.
Yeah.
There is almost no chance of a recurrence. So
it's
only when you have a remnant rectum when you need to follow up with sigmoidoscopies. Otherwise,
I think the other part about if you have made ileal pouch, is there a role for endoscopic evaluation as a screening procedure?
Oh, okay. So I'm not. So I only, the thing I know is that when you have the rectum left, which is occasionally done, that is when you need to do 1 to 2 year sigmoidoscopies.
Yeah, that is right, Anand. But I think this is a specific question about if you made an ileal pouch, whether that bit is at risk for recurrence.
No, it is not at risk.
Yeah.
There is data for that. Yeah.
Correct. That's what Uma wanted to know. So Uma, I think you've got the answer. So I think this has been a wonderful session, and we've answered a lot of questions. And as for myself, I've learned a lot from these talks and panel discussion, because as Sahu said, these are really neglected areas, and we are now seeing more and more patients. Awareness has increased. The genetic counselors are there. We are getting more and more genetic testing done. So I think it was a wonderful way to update ourselves. So with that, I think I have nothing more to add, and over to you, back to the organizers.
Thank you so much, sir. We'll now move on to the debate. Our first debater, so the debate will be on BRCA testing alone versus BRCA and HRR testing for all patients with metastatic prostate cancer. For BRCA testing only, we have our debater is Dr. Amol Akhade, who's a medical oncologist from Navi Mumbai. And for BRCA and HRR testing, we have Dr. Vashisht Maniar, medical oncologist from Mumbai. So I'll hand over the mic to our first debater, Dr. Amol Akhade. Over to you, sir.
Yeah, am I audible?
Yes, sir, you're audible, sir.
Can you handle my screen here? I cannot handle that from here. If you can.
Sure, sir. Sure, sir. We'll share the slides.
Yeah. So I first of all like me to thank the organizers for inviting me for this debate. The topic is BRCA plus non-BRCA testing versus BRCA alone for metastatic prostate cancer. And of course, my stand is clear. Definitely no for non-BRCA genes. Maybe yes for BRCA2. Next slide. So this is next. So this is the typical situation of diagnostic labs when they approach oncologists. Like instead of saying alu lelo and kanda lelo, they keep talking about BRCA lelo, ATM lelo, HRR genes lelo. So quite a lot of us must have seen this, that now in last 4 or 5 years, there are a lot of diagnostic labs which come up with these tests, and they of course try to promote those tests. So next. So this is the era of reverse pharmacology. First we manufacture the drug, then we try to scout cancer to fit the drug, and then in the end, we get diagnostic tests to fit the cancer. So basically we do tests to find out if more tests are required or not. Next. Now there is something called the shrinking denominator. That means when you're ordering a test, you have to understand that out of how many patients the test will come positive, and at the end of the test, how many of the patients will able to utilize that test for a treatment purpose and what will be the benefit. So if you see that it is actually very less, and let us talk about prostate specifically. Next slide. Yeah. So there is a promise that is a real world clinical genomic database to address knowledge gaps in prostate cancer. And if you see that the non-BRCA mutation positivity in prostate cancer is hardly 1%. In fact, BRCA1 is also 1%. BRCA2 is the one that is maximum up to around 10%. But in last year, I think there is a profound trial about benefit of olaparib in metastatic prostate cancer. And based upon that trial, which has shown OS benefit apparently for both BRCA and non-BRCA related genes, and there is an FDA approval. So this entire discussion is occurring because we feel that we have a drug which can be utilized if patient has a BRCA or non-BRCA related genes positive. So we'll talk about the trial next. So the problem is that profound trial has profound errors. Let us talk about first non-BRCA testing. How many patients of profound had non-BRCA mutation out of 4,425 patients? If you see, there were only 8 patients in experimental arm of BRCA1, and non-BRCA genes are hardly 7, 6, 4, 3. So we have single-digit patients. So this goes with the previous data which I have shown that the BRCA1 or non-BRCA related genes, that is other HRR genes, are very rare, hardly less than 1%. So in the clinical trial scenario, if you get these many patients only when you start from 4,450 patients, can you imagine what will happen in a real world scenario? So next slide. Yeah. So did these patients have any PFS or OS benefit with olaparib? No. Look at the curves. This is a curve for PFS1 for a cohort B in a profound trial in which they have given olaparib to non-BRCA related gene patients with metastatic prostate cancer, and as the slide itself clearly shows, there is no PFS1 benefit. Next. There is no PFS2 benefit also. This is exactly the slide which looks like the traffic jams in Western Express Highway, and my colleague Vashisht will agree to that. There is going very close to each other and there is no benefit at all. Next. Now, if you see for the individual gene level testing and the data which is presented in the same profound paper, again for ATM, there is no benefit between control and experimental arm. Next. For CDK12 also, there is no benefit. Next. For PPP 2A, in fact, it is detrimental. There is no benefit. In fact, it is detrimental. Next slide. So look at the OS curves for non-BCR genes. Again, there is no difference between control arm and experimental arm. This is about the PROFOUND trial. Next. And this is very interesting graph. This is the forest graph of the same trial. If you see between favoring olaparib versus control arm, there are only 2 slight dots were on the olaparib side, and one of them is the BRCA1 and one of them is BRCA2. That also, the BRCA2 is much better than BRCA1. The rest of all other non-BRCA genes are on the side of the experimental, so on the control arm. That means there is no benefit of olaparib. Next. So, with such bad curves, do you want to use olaparib for these genes? I won't. And if you see the letters to the editors, the PA of the PROFOUND trial also agrees. If you see this, our trial was not powered for gene by gene analysis. This is only a hypothesis generating trial for non-BRCA related genes. So why to test them? And then why FDA has given approval for olaparib for these genes, and why NCCN recommends to test them? Next slide. Yes. So it is just a play of words. If you see the FDA approval given by for olaparib for HRR gene mutated metastatic castration-resistant prostate cancers, they have only documented about cohort A and cohort A plus B. That means nobody is talking only about cohort B alone, because they know the data of cohort B is itself so bad that there is no PFS benefit, there is no OS benefit. But look at the play of words that they will clump the cohort B with cohort A and show that A plus B is good. So that is why we will test people for A as well as B. This is nothing but play of words. Next. But what about, so basically, till now we have tried to see that whether should we do non-BRCA related genes, and I have clearly shown that at individual gene level and as well as cohort level, there is no PFS or OS benefit, nothing. In fact, the curves are on the wrong side. Now, what about BRCA1 and 2? Next slide. So let us understand the trial population first. This is they have shown an OS benefit for BRCA1 and BRCA2, and how they managed to show that. If you see this trial, they have taken patients who have previously received enzalutamide and abiraterone, and they have progressed, and they have given in control arm probably the drug, and in experimental olaparib. If you see this, almost 20% of the patients have received both enzalutamide and abiraterone in the control arm. So basically, and almost 40% patients have not received docetaxel. Next slide. So profound errors in profound trials. Was the control arm profound trial a good control arm? No. We gave the same drug again on which the patient had progressed. In 20% of patients, which is a lot patients, 1 out of 5, patients have got both enzalutamide and abiraterone before, and still we give the same drug. How many patients in control arm on docetaxel? Only 40%, almost 40% did not get docetaxel. And hence, this is a simple trick. If you want to prove an experimental arm better than control arm, you make control arm weak and then automatically get an OS advantage. And that is what has been done in profound trial. Next slide. So what is the importance of those patients receiving prior taxane? If you see the curves of profound trial for BRCA genes, and if you see the gap between the olaparib and control arm for patients who have not received prior taxanes versus those received prior taxanes, look at the gap between the curves is significantly reduced. That means 40% patients who have not received taxanes are probably driving your OS advantage. If all 100% patients would have received prior taxanes, that much OS advantage would not have seen for BRCA1, BRCA2 also. Next. Now, another trick. What was the treatment after progression? So, simple thing. Those who are in the control arm or the control arm who've got the other enzalutamide and abiraterone, after progression, what they got? They got olaparib. And what the olaparib arm patients got? They got better drugs. They got docetaxel, they got cabazitaxel, they got carboplatin. Next slide. So, how you got OS? We allow crossover and sabotage the control arm. Control arm patients got olaparib, olaparib arm gets docetaxel. So was inferior post-control treatment in control arm responsible for OS benefit in olaparib arm? Yes, it is quite possible. They have made OS in control arm further weak by giving control arm olaparib on crossover and delaying the most important term, that is docetaxel. So those in control arm who have non-BRCA mutation like ATM got further olaparib on crossover, which is a clear-cut inferior drug as per their own analysis. Next. So is PARP, and the last and important question, is PARP pathway driver pathway in prostate? Less likely. We are all senior medical oncologists. Have we ever used the PARP of the PARP inhibitors in prostate cancer rate, cisplatin and carboplatin? Forget olaparib. You see ovarian cancer, there is a data for platinum. If you see breast cancer, there is a data for platinum. Is there a data of platinum drugs itself in prostate cancer? Next. So there is a lot of articles when and how to use carboplatin in metastatic castration in prostate cancer. Next. And next slide, please. Only 2 slides left. So there is a consensus about a meeting in which an advanced prostate cancer consensus conference, almost 33% would use carboplatin or cisplatin in patients which required without testing for BRCA genes or non-BRCA genes, especially if they are progressed and all other options are exhausted. So last slide. So there is no benefit whatsoever in non-BRCA testing, as PARP inhibitors don't work in them. I won't do it. BRCA testing for all metastatic prostate is not cost effective. Olaparib itself is not a defective drug, apart from maybe few patients of BRCA mutations. One may test it only for few patients in the 3rd or 4th line setting when all other options are over and you are really back to the wall situation. And then also better to use platinum drugs rather than olaparib, selectively or non-selectively. Thank you.
Thank you so much, sir. With that, I'll hand over the mic to our second debater, Dr. Vashisht Manyar. Over to you, sir.
Can I share my screen, please?
Yes, sir. Please go ahead.
Thank you. Are my slides visible?
Yes, sir. Your slides are visible, sir.
So thank you so much for having me here. So it's often very difficult to debate with Dr. Amol, and B, find faults with the data he presents, because I respect him a lot. The only fault that I could find in his slide was the date was wrong. It was 2013. It's 2021 that we are sitting. And that's again probably the underlying message also that I would want to give you from my talk, that let's try and look at hypotheses only, because unless we look at hypotheses, we will not come to conclusions. Yes, the data from BRCA is great. Non-BRCA is not great yet, but let's not write over the story as the end of it all. And as science progresses, we believe unless we hypothesize, we may probably not be wiser as we move ahead. Also, secondly, I think from the data that Amol was presented, he himself was not very convinced that we should do BRCA testing at all. And unfortunately, I thought he was supposed to speak in favor of doing BRCA for prostate cancer. I know that he does not do it because I know him well. And to be honest, even I do not do it. I come from the same school of thoughts that I do not believe that these drugs dramatically change the way we treat these malignancies. But for the sake of this debate, as I've been entrusted to talk about non-BRCA HRR genes, let's run through the data. So why do we need to look beyond BRCA and see if there are other genes that we can target? Let's understand that prostate cancer is a disease which is terrible disease. 30% of this disease will, about 40% of the patients that develop prostate cancer will be eventually metastatic. The 5-year survival once you develop metastasis is only 30%. It's not uncommon to see patients who are young, fit, in whom you've used docetaxel, cabazitaxel, lebaretadone, enzalutamide, and these patients are still fit and you have nothing to offer. And the in spite of significant advances, we are currently looking at only a median overall survival for only 3 years. So let's try and see if we have better targets. Metastatic prostate cancer is biologically heterogeneous. It's significantly a mutated pathway. We have PI3K pathway, which is seen in 49% patients, CR pathway in 71% patients. DNA repair pathway is seen in about 23% of all patients. Now, when we talk about why HRR is it important, like we extrapolate the use of HRR for non-prostate malignancies, most commonly ovarian malignancies, and we found that the data is very robust. I agree that the data may be immature as we speak, but I believe it's only a matter of time. And we need to move beyond looking at only BRCA1 and BRCA2 simply because the denominator will widen. So how frequent is BRCA mutation in prostate cancer? About 11% of these are believed to be genomically positive. But if you look at the somatic and germline data, the number rises to as much as about 26%. So here, if you combine BRCA1, BRCA2, germline, ATM, somatic, check 2 mutations, the numbers significantly increase. So from 11.8 simply the fact that you may potentially target about 25-26%. It could be PARP inhibitors, it could be another set of drugs, but remember, these are potentially targeted. It could be platinum. But the point that I'm trying to make here is that we need to find patients who have these malignancies where you have much to offer beyond what you're currently offering. So if you do a matched paired sample analysis of both blood and advanced prostate cancer, you will realize that if you look beyond BRCA, you have almost doubling of the number of patients that you can potentially pick for targeted therapies. So PROFIND trial, really, I agree, there are PROFOUND is, I would not call it profoundly inferior, but I believe it was more of a moonshot trial where it tried obviously to prove that olaparib works in the cohort A arm, where it included both BRCA1 and BRCA2 patients. But in cohort B, it was meant to be exploratory to see if we can use the same drug in these other rare mutations. Yes, I agree with the numbers which Dr. Amol mentioned, and the numbers are extremely uncommon. But for that one person who has that gene mutation, and if you can potentially help that patient, it would be really worthwhile. So while BRCA1, BRCA2, and ATM are best characterized and/or frequently mutated HR prostate cancer, they made no qualms about accepting the fact that the genes which were there in cohort B were exploratory. And about 15 genes were found which they had included in what is called as the AZ-HRR panel. So the primary endpoint, yes, again, there are policies I completely agree, but olaparib did seem to work in BRCA positive patients with a PFS benefit, which was double with an hazard ratio of 0.34. And if you combine A and B both, though the benefit was less profound as it is known to happen, as BRCA is not the same as BRCA, but there was some PFS benefit if both were combined. This is actually a gene by gene median radiological PFS that I could actually get to. And here probably so he did mention, Dr. Amol, that in PP2, R2A and CHEK2 did not have a great response. But if you look at the RAD51B and the RAD54L, probably it did as well as the BRCA gene. The point I'm trying to make here is that exploration is important, finding out new genes are important, and we do not know where we will hit gold. What I really believe the challenges that are there with HRR is the tediousness with which we may end up, which is needed to test for HRR. Unlike BRCA, which can be done germline, here for HRR, you would require an NGS for all patients, and you need at least 20% of tumor tissue. And majority of the time, when the patient becomes metastatic, the tissue is often an archival tissue, and hence the quality of tissue, even in this primary trial, about 30% of the patients. So a very important fact that he mentioned that very few number of patients had these rare genes. Let us understand, amongst those 4,000, about 1,500 patients did not have good tissue. Amongst the 3,000 which did have good tissue, 30% did not, reach the DNA extraction level that was required to get the optimum quantum to test. So I think the challenge is more than pure numbers, is the fact that archiving the tissue is important. And unless we start doing these tests upfront in metastatic patients, we will not get enough sample size to understand what we are looking at. So I believe it's going to be more of an interplay between having adequate histopathological tissue, adequate plasma ctDNA, and maybe a germline testing to understand that, find a bigger denominator in terms of looking for newer mutations, HRR being one of them, where we can provide these patients something beyond standard of care that we are already giving them. Challenges, as I've already mentioned, it's, I believe, more got to do with getting the best amount of tissue. And once we have adequate tissue, we'll probably test more patients, probably find more mutations. Currently, we're looking at this 15 genes. It could be another 5, another 7 genes. And suddenly you will realize that you're looking at newer and newer ways to probably control your prostate cancer better. A small little slide here on is that, is archival tissue the best tissue for getting these HRR testing done? No, in fact, the current one of the papers have presented which have shown that BRCA1-2 alterations are probably higher in your ctDNA than in your archival tissues, including ATM gene. So this also may be an alternative to probably look for more and more tissue. Is it really worth trying to look beyond BRCA? I believe yes, because if you get a higher yield, you're picking up a larger targetable population. I believe you will be able to provide newer and newer drugs and various ways to eventually target a larger number of population. Yes, so why one would argue that it's there because of various other reasons, we cannot ignore the fact that now the NCCN does not an HRR testing done. And also it recommends that we should consider olaparib in men who have an HRR mutated or who have progressed on prior therapy with enzalutamide and or abiraterone, regardless of prior docetaxel use. It also insists that beyond BRCA, we should consider doing HRR testing for all the other rare genes also. And while we keep on talking online, I believe I'm hoping we would meet each other someday. Let's also not forget to treat patients only virtually and look at what they're suffering from. Thank you.
Thank you so much, sir. We'll now go to Amol, sir, for the rebuttal. Over to you, sir.
Yeah, and thanks, Vashish, for an excellent talk. And my point is very clear that I'm not against testing for various genes, provided there is a drug which is very effective against that particular genes. As we have shown in PROFOUND trial, that the drug that with which we are trying to target these particular genes is not at all effective, olaparib. And for platinum, we did not probably have that particular test, especially in a third or fourth line setting when all the options are exhausted. So my problem is that, should I test all metastatic prostate cancers at day one for all genes and increase the cost? Second, if I test them and they end up with some gene, do I have a medicine to offer them which is going to improve their quality of life or make them live longer? For my answer for both these questions is no. If the answer is no, then why to test? That is exactly the point is.
Can I make a small point?
Sure, so please go ahead.
Please.
So I largely agree to what Dr. Amol has to say, but I strongly believe that unless, yes, I agree the cost of currently doing an NGS is significantly more, but I believe in times to come, the cost of NGS may come down. And 5 years back, we did not have targetable mutations for so many illnesses. So I will not be surprised if we keep on doing good, robust, high quality NGS, and then I'm not talking about our clinical practice alone, I'm talking about hardcore, bench to bedside, we will get better targets. And I also agree that we should not be first finding a drug and then looking at targets. Let us find more targets and then find the drug. And that is how old school oncology always was. So yes, I have a problem with first finding a drug and then finding a target. And that's because we're not finding enough targets. So let's try and find more targets. Let people from the bench help us to deliver a better experience at bedside. Thank you.
Thank you so much, sir. Thank you to Vashish sir and thank you to Amol sir for a wonderful debate. We'll now move on to the last part of the session. I now request our organizing chairperson, Dr. Shyam Agarwal, who's a senior medical oncologist from New Delhi, to please give the take-home message for colorectal cancer and prostate cancer. Over to you, sir.
So I think we had a wonderful nearly 3-hour marathon sessions relating to the understanding of high-risk colorectal cancer, screening and how it is happening. So my first thoughts on colorectal cancer would be, I think we started with Dr. Mukherjee, who really gave us, excellent insights into the role of microbiota. And as he said, the infections or communicable diseases causing non-communicable diseases. Very interesting concept. And I believe there are good bacteria, there are bad bacteria, which people are beginning to understand. And it is very interesting to see that they are doing those kind of studies in animal model like mice, where they are using antibiotics or no antibiotics with different probiotics and, different, using those short chain fatty acids and so on, and trying to study the genetic changes. It's really, really fascinating, but I understand it's not going to be easy to translate that kind of work in humans, but at least they've started thinking on the lines of, infectious organisms or infective organisms causing the alterations in immunity, causing the alterations in genes, which could result in the causation of adenomas and other precancerous conditions and ultimately into cancer. So, that brings us to the understanding of, who is a high-risk person, who is an average-risk person, or who is a low-risk person. So I think in the debate or in the discussion, we did, highlight this point that under the age of 50 years, everybody should be sent for genetic counseling. So are we really doing that in our day-to-day practice? Do we have enough genetic counselors to look after patients? Because as Dr. Sahu and everybody else said, the incidence of colorectal cancer is rising in young people by really leaps and bounds. I am seeing, 3-4 cases, new cases of 20 years, 25 years with metastatic colorectal cancer. So we don't understand why it is happening, in younger individuals. Why is colon cancer or why is rectum cancer becoming so very common in younger population? I mean, this was the point of my discussion with Purvesh when we were, and Dr. Uma Dangi when we were, planning this particular meeting. So, I was just looking at things and wanting to say that the transcriptomics, for example, metabolomics. So, those kind of studies are readily available in our setup. For example, we at Gangaram Hospital are doing those kinds of studies in patients whom we are treating with immune checkpoint inhibitors, and looking at the transcriptomics and proteomics and metabolomics in patients who are responding to immune checkpoint inhibitors. And also we are looking at the microbiota. So, those kind of results are going to be coming soon in the next, 6 or 7 months for almost 60, 70 patients whom we have treated with immune checkpoint inhibitors. So the point is that, that information can be collected, number one. Now coming to the screening part. So I think a lot of times we are lacking on screening for patients who are at average risk or who are at high risk of developing colon cancer or rectum cancer. So I think the genetic counseling part is becoming very, very important, especially when the younger people are getting affected by this disease. And of course, the role of MSI, the BRAF testing in the familial cancers or hereditary cancers has become so very critical and important today. And we must not miss those cases because it is critical to analyze those patients. Now coming over to the prostate cancer. So I think we did a panel discussion and then we asked people at what point in time they will do the BRCA1, BRCA2 testing. So nearly 50% or even less said at the first diagnosis. Most people said when they're escaping the first line of hormonal therapy. So I think the important message here is that we must do the BRCA1, BRCA2 and ATM gene for sure, because these 3 genes, there is ample data and approvals. Although I know there is a debate on ATM and other genes which belong to the HRR category regarding the benefit of olaparib, but then rucaparib is there where it has the approval post taxane. So I think not only these 3 genes, but other HRR genes should also be looked into at some point in time in the management of CRPC, because nearly 20 to 25% patients will have these mutations in the HRR genes. So you cannot just afford to miss these, especially when the generic like rucaparib is available, and it should be kept in mind all the time. And it should not only be, it should actually be looked at in the tissue rather than looking into the blood. So once you have done the tissue, if you find a positive test, then you can look for the germline testing in the blood. So I think these are very, very important considerations which are emerging in the risk stratification of colon cancer and prostate cancer. And I think it is really very, very important for us to pass on this message to our friends or colleagues through these meetings so that we don't miss patients and we really treat them appropriately based on the guidelines for management of high risk colorectal and prostate cancer cases. So with this, I thank Purvesh and Dr. Uma Dangi for this opportunity to organize this very important meeting. Over to the organizers. Thank you very much.
Thank you so much, sir. I now request our program director to please give her comments before we move to the vote of thanks. Over to you, ma'am.
Hello, everyone. I'm really thankful for the attendance that we've had and the exciting and the very active discussions and debates that have happened today. And I really believe that this is a very important topic, and probably in the future we are going to be be doing more and more genetic testing. So I thank you all for being here and attending and taking active participation. Thank you, Dr. Purvish Parikh sir, for vote of thanks.
Thank you very much, Dr. Uma. I think Dr. Shyam did a fantastic job of summarizing the entire discussion that we've had. And if anybody has attended what Shyam said, I think he would really get the gist of the discussion. But right from the discussion on colorectal cancer microbiome by Mukherjee, and then from Selech Bhandari, Parini Sahu, Prasad Narayan, and then Vamshi Krishna doing the panel discussion, and this intense debate that we had between Amol and Vashish about prostate cancer, we have really enriched ourselves today about high-risk population for colorectal and prostate cancer. Tomorrow is a gap, and we will continue on Sunday at 12:35 p.m. sharp. So we hope that you will have an early lunch on Sunday and be ready to, take part in this wonderful high-risk high-risk cancer population conference. With that, I thank everybody. Wish you a happy dinner, happy evening, and see you again on Sunday afternoon. Good night and take care.
Thank you so much, sir. Thank you, ma'am. With your permission, I'll end the meeting.
Yes, please.
Thank you so much.